Oh shit. Oh shit.
Hey, Al, your camera's on in your pocket. Al Ravowski. Isn't it Al? Yeah. There he is. Hi, Al.
Hello.
All right, guys, it's 6 o'clock. Going to get you started on time here today, and hopefully get us out of here on time today. Today we have Justin Coper, the Continuous Improvement Manager from Health Nut Air Medical Services in West Virginia, a YSU alum. He's going to be talking to us about pediatric transport, provider hygiene, safety, and vaccinations. Justin's been with us before. He's a good speaker. He's always interesting. So hopefully he can keep that subject interesting too. After that, we'll have Larry Monero. We're all familiar with Larry. He's a paramedic and medical student, and he has been instrumental in these in this education and in these protocol changes. He'll be talking to us about EMS research and evidence-based guidelines. So after tonight, this is the end of the National Register NCCP standards. The rest of the program will cover the additional hours required for Ohio recertification. The rest of the lectures allow us for a little more leeway and a little more diversity. So even if you don't need the hours, technically need the hours, please feel free to join us. I think we'll have some good speakers and some good topics. No knowledge is ever wasted. So as far as around here, the COVID numbers are on their way down. It's been very encouraging the last couple of days. Keep your fingers crossed that keeps going. We peaked at about 52 or 53 in our hospital, and in a matter of the last 5-6 days, we're down in the teens. So hopefully that keeps on going, and hopefully that's how it is for the rest of you. So without any more delays, hi, Joe. We're going to go.
Matt, just one quick reminder to remind everybody, for the state, it's not necessary for the NCCP for registry, but for the state, they have to do that trauma triage program, which is online. You have to do it every cert period. And then the other piece what was it, Matt? The rescue. Larry, I think you guys said you only have to do it once.
Yeah, it's Rescue Task Force. It came out a couple
Force.
years ago, and if you haven't had it in any of your training, you're required to also do that online. And the state will look at that, and you just go to the Ohio Department of Public Safety training campus, make an account, and they'll have those 2 courses for you there. So because you can get it there, we don't want to have somebody talk about it. We'd rather bring some diverse lecturers and talk.
Okay, thanks. I just want to put that out as a reminder.
No, appreciate it. So, Justin, if you're out there, feel free to take it away when you're ready.
Yep, well, let me get my screen shared here. You talked me up about it being interesting. I'll try to make it as interesting as I can. The latter half of this, I'm going to forewarn you, is pretty dry. It's part of that national component, but I'll try to make it as interesting as I can. I also have the teams up on a separate device as well to kind of keep an eye on the chat. So if you do have questions or anything, just feel free to pop them in the chat. To start out, though, we're going to talk about pediatric transport. For us as EMS professionals, this is definitely one of the more nerve-wracking type of calls that we're on. We tend to not take a lot of pediatric transports usually. So we kind of run into situations where we're trying to make stuff up on the fly, and we're going to talk about some of the national best practices out there for how to safely transport kids, even if they may not be a patient. So if you have mom that's a patient and you got a kid on scene. So learning objectives, we want to talk about operational safety issues related to the safe transport of children by EMS. It is an issue nationally. Talk about the ideal methods for pediatric patient transport in multiple clinical scenarios. These clinical scenarios actually were published by NHTSA, the National Highway Traffic and Safety Administration. They're the ones that are issuing the safety recommendations on car seats and everything. So these people are pretty much the experts on how to safely transport kids. They put together a work group in 2012, and they came up with these guidelines specific for EMS, and that's what we're going to talk about tonight. And then we're going to talk about the NHTSA guidelines for post-crash use of child restraint systems. So if you show up on scene and the vehicle was involved in a car crash, what the determining factors are on whether or not you can continue to use that car seat for transport to the hospital, or even if you're giving advice to the parents, let's say they sign a refusal, if you need to tell them, hey, this crash met this criteria, you need to replace this car seat as soon as possible because you can't continue to use it. And then we'll also talk about how to secure a child safety restraint to an ambulance stretcher. I don't normally throw this in on most of my lectures, but I am mentioning specific products tonight. So we're going to talk about things like the PD-Mate, NeoMate, things like that. I don't receive any financial contributions from any of these product manufacturers. If you know somebody that's willing to hook me up with one of those financial contributions, I'll gladly change this slide. But as of right now, I have no vested interest in any of them. They're just the ones I'm familiar with. So I'm sure we've all heard this in some pediatric course, whether it be PALS, PEP, NRP, EPC, any of those pediatric specific courses. We know that kids are not little adults. The body habitus, the overall way you secure, transport them, interact with them, physiologically treat them, they're all different. And one of our biggest challenges when we're looking at how to safely transport these kids is poor stretcher design when we consider the needs of a pediatric patient. If you go to Stryker or Furno, or if there's any off-brand Chinese cot manufacturer out there, they're all designing these ambulance stretchers for the 6 foot tall, 100 kilo adult male patient. And we know that because when we get those 6'5" patients on the cot, we always have to put a towel on their feet because they're kicking us in the chest every time we get them in and out of the ambulance. So we know that these ambulance stretchers aren't really designed adequately to secure smaller individuals. And that presents a unique safety hazard for pediatric patients. If we try just securing a 20-kilo kid to the cot with the existing strap system and shoulder restraints, it's probably not going to hold them securely enough if you're involved in a motor vehicle collision. The other problem working against us is these are extremely low volume calls. We don't run kids a lot of the times, unless you're working for a specific pediatric agency, whether it be Akron Children's out of Boardman or out of Maine. We have a ambulance within our system that is specifically dedicated to the West Virginia University Hospital children's team. They do nothing but neonatal ICU and pediatric ICU transports. They're extremely familiar with this, but our average ALS staffed truck on the road, they're not running kids 80-90% of the time. As a result, there's not a lot of education out there, either in initial training or in ongoing training, on how to properly secure these kids. That was one of NHTSA's big pushes, is when they're revising the NCCP standards, they wanted to talk more about how to safely transport pediatric patients. I feel we do a pretty good job training on pediatric medical scenarios and trauma scenarios, but a lot of those scenarios end at, we're going to go en route, and really never discuss how you're going to take them en route. And the last big problem with kids, and I'm sure you've seen this and we experience this all the time in West Virginia, we could have a 13-year-old that weighs 60 pounds. We could have a 13-year-old that weighs 180 or 220 pounds. So judging a patient's size based on age is not exactly an accurate way to look at these patients. So you could have an 8-year-old that requires multiple different securement methods depending on their overall body habitus. So when we're thinking about an ideal world, this is how all kids would be transported in motor vehicles. This is the standard usage for car seats and child restraint devices that normal people use in their cars every single day. And one of the surprising things is you can actually see that they're trying to keep kids rear facing up until 3 now. That used to be only until 2, and then you could put them forward facing, which you can still put them forward facing at a certain point and wait. But the data's out there that says these kids fare a lot better in motor vehicle collisions when they're rear facing, because as their necks develop more musculature, they can safely hold their head in place in a collision the older they get. When they're at the younger years, they don't have enough strength in their neck. It's kind of the old adage of a watermelon on a toothpick. If you get a kid that's forward facing that doesn't have a well-developed neck muscles and everything, you have a really heavy head, and that could potentially cause some cervical spine injuries. So they transition from a rear-facing seat to a forward-facing to a booster and then to a normal seat belt. Unfortunately, we don't have that reality of, the ideal world in the back of our ambulance, because this is our reality. We have a lot of unforgiving corners, unforgiving spaces in an ambulance. We have our ambulance stretcher, which by itself with no augmentation isn't exactly the best place for a 10-kilogram kid. Now, in this ambulance, the one thing that's extremely progressive and may come up later in this lecture that we'll discuss is they have forward-facing captain's chairs. That's going to be a huge design consideration moving forward as we think about transporting children in ambulances, because rear-facing captain's chairs present a little bit of a problem when we have a car seat that's designed to be rear-facing only. And we'll talk about that here in a few minutes. Overall, though, we want to take certain precautions to protect all patients in the back of our ambulance, regardless of whether they're pediatric or not. Our goal is to make that patient care area as safe as possible, not only for the patient, but selfishly for us. And that just starts with policy and procedure to benefit all ages. So some of these considerations are just generally good practices to get in the habit of, regardless of who you're transporting, whether it's a geriatric or a pediatric. Biggest one, seatbelt use for all occupants all of the time. This is the biggest cultural battle that we face in EMS. But I kind of frame it to some of our newer employees who aren't used to wearing seatbelts in the back of the ambulance all the time. I give them a clinical scenario. Let's say you roll up on a motor vehicle crash. Kid was ejected out of a car because he was not restrained. Parents are on scene, are uninjured, and the child is the only one injured because he was ejected out of the back seat. He's 3 years old, was never in a car seat. You get the kid packaged up appropriately and everything. You are naturally doing what? You're judging those parents. Why wasn't this kid properly restrained? Everything in that car was a hazard. And then we get in the back of the ambulance and proceed to do the whole 20, 30-minute trip to the hospital completely unrestrained. And if we get in a crash, I know me, I used to be a 160-pound projectile. Now I'm closer to 180, 190 because flight crews eat well. But we turn into essentially large projectiles in the back of that ambulance because we're not secure and we are a risk to that patient. And we're doing the exact same thing that we just judged the parents for. So we really need to have a wholesale mindset change on seatbelt use in the back of the ambulance. Now, it's not all our fault. A lot of the times, ambulance design in the back really hasn't been conducive to wearing a seatbelt and doing patient care at the same time. A lot of the times you can't reach everything that you need to get to. So you will see ambulance design start to change over time to better accommodate proper restraint use in the back. Next thing, check and maintain all pediatric transport equipment. If you have a PediMate on your truck and that's the only thing you have to transport kids, well, you should probably to make sure that A, you have it and it wasn't left at a hospital somewhere. B, all the straps are working appropriately so you can actually buckle the kid in. And C, do you actually know how to use the device? So pull out the PediMate if you haven't used it in a while and get a little bit more familiar with it and make sure that it's still in good working order. Follow current pediatric standards of care for ill and injured children. That kind of goes without saying. Proper driver selection. If you got a super sick kid and the person, you have your choice, you got two people, one of them's all keyed up because they got a kid the same age and they're just, wrapped around the axle, and you got somebody else on scene that isn't quite as emotional, you probably want the least emotional person driving you to the hospital if you got a super sick kid. A, you're going to need a smooth ride, and B, you want to get there in one piece. Reduce use of lights and sirens. We've talked about that in many different lectures throughout this whole refresher series, that the measurable benefit of lights and sirens is minimal the majority of the time. There's very limited clinical scenarios in which the use of lights and sirens is clinically beneficial to the patient. And that's the mindset we need to be in. Everything we do operationally needs to have that clinical mindset to it of what is this going to do to either benefit or harm the patient. And then next thing, secure all equipment. I put this in here, it says glove box rule. The way I always looked at the back of the ambulance once I started flying was kind of framed by a conversation I had with a gentleman by the name of Jonathan Godfrey. He was the sole survivor of a medevac helicopter crash into the Potomac River in 2005. They were flying along one night at 200 feet. Next thing he knew, he woke up underwater, still strapped to his seat. His flight nurse partner and pilot were killed. And he said, having been in a very violent helicopter crash, I looked at the back of that helicopter and realized everything in the back of that helicopter would have been a missile had it not been secured. So his rule moving forward after that is look at everything in the back of your ambulance. If you don't feel comfortable with your partner picking it up and throwing it at your face as hard as they can, it needs to be secured. So pretty much anything heavier than a box of gloves probably needs to be secured and have its own individual place, because in a collision, all that stuff's going to come loose. And I could only imagine what a loose oxygen tank would do to one of us, let alone a 1-year-old kid that's secured to the cot. So look at the back of that ambulance with a very critical set of eyes and secure anything that you think could be a projectile hazard. NHTSA's ultimate goal for us when we're transporting children, they want us to do these 3 things all simultaneously. They want us to prevent forward motion and ejection. They want us to secure the torso, and they want us to protect the head, neck, and spine. The National Association of State EMS Officials took this one step further, and they put out guidelines that said EMS agencies and EMS providers should have the proper equipment, training, and knowledge to properly secure any pediatric patient ranging from 5 to 99 pounds. So essentially, if they're less than 100 pounds, they want us to have some idea of how we're going to properly secure that child with the proper equipment in our ambulance and not just rely on the stretcher system for a 32-pound patient. So how do we accomplish that? Well, that's a little challenging if we don't have the proper equipment and training. So we're trying to get the training done tonight. Go back to your agency and actually look at the equipment that you're using. And at least if you don't have everything available to you today, know the limitations and the use criteria for each of those pieces of equipment. Ultimately, one of the things that all kids are going to have or should have is a child restraint system. And by that, I mean their car seat. This is ideal for the kids that are really, really stable because they're familiar with the look, feel, color, and smell. So it's not foreign to them. It's nice, warm, and cozy. It's what they're used to. And chances are you get them in their car seat, you turn the lights down, and they're stable. Chances are they're probably going to sleep on the way to the hospital more so than anything else. So it results in a lot less patient agitation. But ultimately, this should only be our first line option if we truly have a stable kid. So if we have a kid that we need to do a lot of continuous stuff or medical interventions on, this really shouldn't be our first option because it's going to limit access to that child, whether it be evaluating the patency of an IV, evaluating the patency of a patient's airway, regulating body temperature, things like that. The most important thing to remember with anything in pediatric transport, whether it's a car seat or some other device, never use them on side-facing seats. So the side-facing captain's chairs, the side-facing bench seats, side-facing CPR seats, these child restraint devices are not designed to take lateral impacts like that on a routine basis. They are designed and tested with front and back forces in mind. They are not meant to take those lateral forces, nor do kids fare well when their necks have to take such a large lateral hit. We just talked about how their necks really aren't all that developed at a super young age to hold that weight up there. Well, imagine putting a car seat in the CPR seat and you get in a head-on collision with another vehicle going 60. That kid's going to have an absolutely horrible outcome where had he been rear-facing in line with the crash forces would have fared a lot better. So no matter what you do, never secure a child on a side-facing seat facing sideways. Ultimately, when we're looking at child restraint systems, we want to secure them on the cot or a forward-facing captain's chair. There's a reason for that. If we have a child safety seat that is designed to be rear-facing only, and we put that child in a seat that is already rear-facing without any sort of belt to secure it through those forward belt loops, that's not really the way it's designed. So we can put this seat, though, on the stretcher system and then put seat belts through the normal belt path, and that would be the lap belt. And then we could also put the chest belt through the forward belt path, so it's secured in multiple spots. So the child restraint system ideally gets secured on the stretcher. We want to make sure that the seat does have a 5-point internal harness. We want to position the seat facing the rear of the ambulance. Make sure you elevate the cot backrest up to the fully upright position, so that way it supports the back of the seat as much as possible. And you just want to make sure that kid's snugly secured in there. So this is kind of the number one question, though, that comes up for EMS providers. And I'm sure if I started a poll, let's say we roll up on scene and mom is complaining of mild chest discomfort. They got T-boned. There's some damage to the kid's door, but other than that, kid seems to be doing fine. I'm sure I'd get a bunch of different answers on whether or not we can use that car seat for transport to the hospital, or if mom can use that car seat after that crash. Good news is NHTSA is really clear about these recommendations. They want all parents, providers, you name it, to replace a car seat after a moderate or severe crash. You do not, however, need to replace it after a minor crash, but you have to have all of these criteria below apply to be considered minor. So first, vehicle has to be driven from the scene. Excuse me. So if the vehicle has to be towed, needs massive repairs, well, that's out. You got to replace the seat. So if the vehicle is able to be driven from the scene, then you have to look at the vehicle door nearest where the car seat was secured in the vehicle. If that door is damaged as a result of that collision in any way, do not use that seat, because that obviously shows there were some impact forces at the point closest to that child in the vehicle. So let's keep going down the list. So if the vehicle is able to be driven, there's no damage to the door, then we evaluate the vehicle's passengers. If none of the passengers sustained any injuries, then we're still good, as long as the airbags did not deploy if it was equipped in the vehicle, and if there's no visible damage to the seat. Once we meet all of those criteria, all 5 of them, we are good to keep using that seat. If any of those criteria fail, so let's say all the damage and everything is okay, but like I said, mom's complaining of chest pain from hitting the steering wheel, we got to replace that seat because there was enough force in there that it could have caused an injury to a passenger in the vehicle. So according to the federal regulators, that's exactly what the criteria is for seat replacement. So let's look at if we can't use a car seat, or a car seat isn't available to us at the time of the transport. So let's say a kid got taken to Salem Community Hospital and then got transferred up to Akron Children's Boardman. Akron Children's Boardman doesn't have transport available. They need to go to Maine, and parents are already on their way to Akron, and the car seat's in the parent's vehicle. So you don't have a car seat available to us. Well, then we can look at things like the PD-Mate, the PD-Mate Plus, and yes, there is a difference, and I'll explain what the difference is. The NeoMate, ACR4, which stands for Ambulance Child Restraint. And then if you do need to do spinal motion restriction, we still have PEDS boards that are floating around out somewhere in the periphery of EMS. Those are still an option. This is most commonly what's on all of our ambulances, and has been for the 15 years I've been doing it. It's the traditional PD-Mate. A lot of people don't realize that this is only good up to 40 pounds. I've seen crews roll into hospitals and they got a 52-pound kid in a PD-Mate. Ultimately, if nothing bad happens on the way to the hospital, no harm, no foul. But if you get into a crash, it's really not designed to contain all of those forces for somebody that's above the weight limit for the piece of equipment. That would be essentially the same as putting a 700-pound patient on a cot only rated for 600. So you're kind of taking it upon yourself if you use it outside the manufacturer's specifications. These are some of the things that at least monthly, according to the user's manual, need looked at to make sure that it's still in good serviceable condition. You want to look for excessive wear. You want to look at the stitching to make sure that nothing's coming unstitched. Make sure the plastic buckles and adjustment tabs are still intact. Sometimes, especially that chest piece right there, sometimes that'll snap off. If that chest piece is broken and it can't hold those straps together, that PD-Mate needs taken out of service and they need to get a new buckle for it. And if there's any cuts or tears in the actual canvas backing or any of the straps, it needs removed from service. One thing that I don't think was really clearly communicated years ago when we got these is bleach containing disinfectants actually damage the canvas on this and weaken the straps, the glue, the stitching, all of that. So if you are using bleach wipes on this, please switch to something else like the Purple Top Sanitized wipes, the Striker Sidekick wipes, anything that does not contain chlorine bleach, because it'll actually degrade the quality of the canvas and everything on this device. Next is the PediMate Plus. So you will know if you have the Plus or the traditional because A, it's going to look newer because this hasn't been out as long as the traditional PediMate, and you'll have a different logo in the upper right-hand side or here where it says PediMate Plus. The reason it's called Plus is this will actually accommodate a child from 10 to 100 pounds. So you can see how much more advantageous this is to you as an EMS provider, and this is why I gave that financial disclosure at the beginning. I could care less which pediatric restraint system you use. You just need to know the limitations of the one that you're using, and if all you have available to you is a traditional PediMate, you kind of have a gap from that 40 to 100 pound margin where you're going to have to figure something out. So like I said, this goes up to 100 pounds. This has the same maintenance and decontamination concerns as the older PediMates regarding bleach, and also has the same monthly inspections. So just check the same things on this on a monthly basis. One other really cool thing that's out there that we actually had on our aircraft for a little while before we switched to the ACR is something called a Neomate. Furno, who makes the PediMates, quickly recognized, hey, with this PediMate Plus, we're doing great. We have a solution for 10 to 100 pounds. But if we think back to that NHTSA recommendation, there was still a gap from that 5 to 10 pounds. So those really small neonates, how do we secure them? Well, they came out with the Neomate that covers the age range of 5 to 14 pounds. So with a Neomate and a PediMate Plus, you would be able to cover that entire weight range of pediatric patients. One other option that's out there from a completely different manufacturer, this originally started in Great Britain and then kind of came over to the US. And this is actually what we use statewide across West Virginia for a lot of primary 911 agencies and also for us in flight. Our state EMS for children actually got grant funding to give a lot of agencies free versions of these. It's the Quantum Ambulance Child Restraint 4. And the reason it's called the ACR 4 is there's 4 color-coded restraints that correspond to different weight ranges. So this goes from extra small at 4 to 11 pounds, small 11 to 26, medium 22 to 55, and large 44 to 100. So there's some overlap between the weight ranges. You just select the one that's appropriate for your pediatric patient, secure the base of it to the ambulance stretcher, secure the weight-specific attachment points to that base, and just go from there. Comes in a small duffel bag. It's actually a really small portable device. So these are actually pretty handy, and I've had some good experience with them. Next, let's talk about some clinical scenarios. We mentioned these earlier. You know, what are the ideal transport methods for children in various clinical scenarios? These are the ones we're going to talk about tonight. So first off, a child who is uninjured or not ill. So this is the call where you show up and mom's having a heart attack. She's the only one home with the 4-year-old, and you got to take mom to the hospital because she's having a heart attack, but you're the only ones there. Nobody else is home. What do you do with this 4-year-old? Next is an ill or injured child who does not require continuous monitoring or interventions, so that child that's really stable. Next is ill or injured child who does require continuous monitoring / interventions. Fourth, requires spinal motion restriction and or being transported supine. And then last is a multiple patient transport. So for that kid who's really not a patient, not injured or not ill, you're there for somebody else. Ideally, the transport occurs in another vehicle. That's the safest place for that child. You have enough things going on in the back of that ambulance with your own patient, regardless of what's going on with them. You don't need the complication of now having to delay patient care and worry about another kid. But you can't exactly just ditch that 4-year-old on scene if you have no other alternatives. So let's say, nobody else is there, you still got to figure something out. Next option is a child restraint seat in the front seat of the ambulance with the airbag switch turned off. If you do not have the ability to turn off the airbags in the front of the ambulance, then that's not even a viable consideration. That's out the window immediately. Next is child restraint seat in a forward-facing EMS provider seat. That's currently rare in our industry. You saw that picture where they have the forward-facing captain's chairs in the back. That would be the ideal spot for a car seat. Next is child restraint system in a rear-facing EMS provider seat. Some of our ambulances, the airway seat has the integrated child restraint system in that. If you do have one of those, please make yourself familiar with the operations and limitations of those. I guarantee you there's a published weight range and potentially height range for children to be able to safely fit into that seat. If you don't know what that is, ask your supervisor, ask your chief, lieutenant, captain, whoever. If they don't know, look up the manufacturer or call the manufacturer during the week and see if you can get information on the seat that was actually installed. Good rule of thumb is if you have those integrated child seats, just take a label maker or something, and when you fold that down, put a label maker note on the inside of that seat with the height and weight ranges, so that way anybody who uses that ambulance, even if it's 2 years after you've left that agency, as soon as they flip that down, they're going to know what they can and can't use that seat for. So once you find that information out, make sure it's coming from the manufacturer themselves and just document that somewhere in the ambulance. Best place is on the inside of the seat as soon as it flips down. Last option is leave on scene under appropriate adult supervision. So if there's a family member there that the parent is okay with them watching the child, if it's a trusted neighbor of the parent, or another option that a lot of people don't consider is another EMS crew or law enforcement. If this is truly a critical patient, we don't have a lot of time to figure this out on scene. Sometimes calling for a law enforcement backup to say, hey, we have an unaccompanied minor on scene we can't safely take in the ambulance. Mom's in critical condition. We need law enforcement to come on scene and at least sit with this kid until we get this figured out. Even offer up to law enforcement, hey, we'll come back and help you figure this out, but we got to get mom taken care of. Next is injured or ill that's stable, so no monitoring or interventions. Ideally, we want a proper child restraint system secured on the cot, whether that be a car seat. If a car seat's not available, then we can use one of our PD mates, neomates, whatever the case may be. Alternatives, child restraint system in a forward-facing seat, like we already mentioned, in a rear-facing seat, and then the least ideal option, but this is in the NHTSA manual and recommendations. If you have no other method to secure that child in an approved device, they do say secure child on cot using 3 horizontal restraint shoulder straps. I will caution you that is the absolute least ideal method to transport a pediatric patient. You should try everything in your power to avoid doing that. Next thing is injured or ill, and the patient does require monitoring or interventions. You do not want this kid going in a car seat because you're going to have to perform interventions on this child. You're going to have to do continuous medical monitoring. So you're probably going to be limited if this kid's in their own car seat. So that's where you want to use that pediatric specific transport equipment. Alternatives, we already talked about securing the child on the cot, but that's the least desirable alternative. We'll put it that way. If a child requires spinal motion restriction or transport supine, there's the pediatric spine board. Those are still around. I'm not going to quote weight limitations on that because those are manufacturer specific. A lot of the pediatric spine boards are both height and weight limited. So just look at whatever one you're using at your agency. The alternative is a standard spine board with padding and secured to the cot. And one important point about the pediatric boards, if you are using one of those, use one of the foot straps that isn't going to actually touch the patient and use that as a tether to prevent the board from sliding forward. So if you get in a front end collision, you have that foot strap that's actually going to hold that pediatric board to the cot itself and prevent it from going forward. If you have multiple patients, you ideally want to transport each as individual patients. This could be mom and newborn baby. This could be multiple children on scene that are all sick and requiring transport. Ideally, we want to transport them each in their own transport vehicle because they're each patients. One important note, these days are gone. Never transport a child on a caregiver's lap or in a caregiver's arms. First thing that's going to happen if you get involved in a crash, especially a rollover crash, no matter how hard you try to hold on to something, let's say that kid is 10 kilos. If you get in a 20G collision, that's a 220 kilo force. I don't know too many moms and dads that are going to be able to hold on to that in a rollover. So the days of mom or dad sitting on the cot and holding the child for transport not secured, those days are gone. These kids need to be in pediatric transport specific equipment. So when we look at the future of PEDS transport, NASEMSO is leading the Safe Transport of Children Committee. Ultimately, they're encouraging the use of pediatric-specific EMS equipment for transport. They're really wanting us to get away from using car seats to transport children in ambulances. Their reason for that is not to be difficult. Their reasoning is that those car seats were crash tested in normal civilian automobiles. They were never crash tested on ambulance stretchers or in captain's chairs. So the crash testing data that proves those seats are safe, all of that's pretty limited when we look at its application in EMS. So that's why they want to go with EMS specific equipment in the back of ambulances. So in summary, these are kind of do's and don'ts really quickly from actually the Pennsylvania Department of EMS. So secure kids in an appropriate restraint system. Consider their age and weight when determining an appropriate restraint system. Transport children who are not patients properly restrained in an alternate vehicle whenever possible. So we talked about that. You can allow parents and caregivers to ride in the patient compartment with their child only if they're also properly restrained and in accordance with your agency's specific policies. One thing I will caution you, you really need to advocate for caregivers on special needs patients. So if you have a child that has special healthcare concerns, you definitely want that caregiver with you in the back because they're going to be the subject matter expert on everything that is with that child. Don't transport the child on a patient's lap on the stretcher. Do not transport a child on the bench seat or CPR seat. We talked about that. Don't transport children in their own safety seats if it was involved in a crash that was moderate or severe. And don't leave anything unsecured in a moving EMS vehicle. So with that said, does anybody have any questions on the first half of tonight's presentation from me? All right, give me 1 second to get the other PowerPoint pulled up and I'll be right back with you.
Go ahead and take a quick break, guys. Put your hands up, please.
Matt, thanks.
No problem. That worked out.
Yes, sir, finally. Thank you.
All right.
Okay, what's the hands up?
That's part of how we keep track of how everybody is in the class, Sheila.
Okay, I'm like confused.
Yeah, when we take a break, we ask everybody to put their hands up, and then when we come back, take your hands down. And then, so like, if someone doesn't put their hand up the whole time, if they don't send me an email or something, we know that maybe they're not paying as close attention as they might should be.
Right, sorry, I was like, I don't know the hands up. I don't even know how to do the hands up, so.
That's all right. How about if I just take you at your word?
Okay, I'm still here.
You can go whenever you're ready, Justin. Vaccinations, huh? Shouldn't be any arguments on that.
No, it's probably the least controversial topic I've ever written a PowerPoint on. Should be just all rainbows and butterflies and us singing Kumbaya and We Are the World, right?
Right. It's all very clear cut.
Yeah. The science is translucent. All right, so yeah, we'll go ahead and get started in the interest of time. This one should be a little bit shorter, so I'm hoping to end right at 7. Yet again, anybody's got any questions, comments? If you want to throw mud at me about the vaccination stuff, I'm in the chat too, so feel free. Do whatever you want. This was added into the National Registry research stuff, mainly because we pre-pandemic really didn't do a great job in EMS about infection control. Everybody kind of recognized that it wasn't specific to the US, and believe it or not, it wasn't even just specific to paramedics or EMTs. The nursing profession had its own criticisms of that. So some of the learning objectives, we're going to talk about hand washing, as boring as that is. We're going to talk about the recommendations of vaccines for healthcare providers. That might get a little spicy. And we're going to talk about eye safety indications and measures. That is one thing that, yet again, pre-pandemic, we didn't do a great job of putting eye protection on and face protection when we needed it. It was always just, well, we threw on gloves. What else do you want? So we'll talk about that. Right now, the status of hand washing in EMS is probably better than it has been previous to the pandemic, but it's probably still not great. There was a study done in 2014 published in Pre-Hospital Emergency Care. They found that EMS provider compliance with infection control recommendations is suboptimal. And believe it or not, that was actually the title of the research article. They did an observational study at a bunch of hospitals, found that only 28% of EMS providers washed their hands after having contact with a patient, and 57% wore gloves. So 43% weren't wearing gloves, and 72% never washed their hands. And they found also that 32% disinfected reusable medical equipment. So that kind of left a lot of room for improvement. 2015, there was actually a study done specific to EMS providers in Ohio, determining what is the overall prevalence of MRSA of the nares in EMS providers in Ohio. They detected MRSA in 4.6% of EMS personnel sampled, and they sampled people from all 10 regions of Ohio. And they found that the greatest correlation between somebody's individual actions and them having MRSA, those that did not practice hand hygiene, the odds ratio of them having MRSA was 10.5. So huge increased odds of having MRSA when you did not practice proper hand hygiene. So we want to practice hand washing before and after patient contact. Before for us is a little tough because we're in an ambulance, but definitely after. Before eating, after cleaning the ambulance or equipment, please wash your hands after using the restroom, and after nose blowing, coughing, or sneezing. We can use soap and water when hands are visibly soiled. That's the ideal thing. If hands are not visibly soiled, then we can use an alcohol-based hand sanitizer. There is a little bit of limitation there. One of the things that everybody forgets is to remove all jewelry. So rings, watches, anything like that, germs are going to accumulate there just like everything else. If you're like me and you wear an Apple Watch everywhere, best practice is get a case for your Apple Watch so you can disinfect that. And also have something that's going to stand up to being disinfected, like a silicone wristband or something. Wet your hands with clean running water, apply soap, scrub the back of your hands, clean underneath your fingernails, in between fingers. Biggest thing, rub your hands with soap and water for at least 20 seconds. Rinse them well under running water. It says dry hands using a clean towel or an air dryer. I think the jury's out on the air dryer. I think it spreads more than it does any measurable benefit. So I would say paper towels are probably better. If you're using an alcohol-based hand sanitizer, just make sure it has at least 60% alcohol content. So that way it's actually going to kill the stuff on your hands. Reduces the number of germs. It doesn't eliminate all types of pathogens. The one thing that alcohol-based hand sanitizers have always struggled with are spores, specifically C. diff. So if you have a C. diff patient, don't rely on alcohol-based hand rubs to make your hands safe to eat. Less effective against viruses. It does create an inhospitable environment on your hands for viruses to replicate, but ultimately you want to wash with soap and water. Same thing, remove all jewelry from the hands and wrists. You only need about a dime size amount of alcohol-based hand rub. Rub your hands together. Rub all surfaces of your hands and fingers until they're dry. Don't dry your hands with a paper towel or another towel prematurely. Just like disinfectants have to be on a surface for a certain amount of time in order to kill the amount of pathogens that they're rated for. Same thing with these hand sanitizers. They have to be on your hands for a certain duration. They don't kill these things instantly. So rub that stuff on your hands until they're actually dry. And then always remember, wash your hands with soap and water when it does become available. Eye and face protection. It protects us two ways. First, it protects us from ocular exposure. So some body fluid going directly onto the globe of our eye. But more so, it protects the mucous membranes of our eyes. We need to use eye and face protection based on certain pathogens and also based on certain procedures. Biggest thing with eye and face protection, what they think the biggest measurable benefit from eye and face protection is a habit change. You end up not touching your eyes and face as much when you have that stuff on your face. So it kind of protects those mucous membranes from touching your eyes, which we do hundreds of times a day and don't even think about it. So that's probably the biggest measurable benefit. Can be comprised of goggles, face shields, safety glasses, full face respirators. Just know prescription eyewear does not constitute proper eye protection from exposures to body fluids, droplets, or aerosols. You actually have to be wearing safety rated eye protection. Some pathogens that require eye protection, these are all either droplet or airborne. A lot of these are droplet. Meningitis, mumps, strep pneumonia, parvovirus, pertussis, pneumonic plague, rubella, seasonal influenza, streptococcal pharyngitis, or strep throat as it's known, because if those people are coughing and hacking, and you're sitting close to them doing a neb treatment or something like that, the last thing you want is all that stuff in your face. Procedures requiring eye protection, definitely intubation, including video laryngoscopy. A lot of people are like, well, we use a we do video laryngoscopy on everybody. We don't have to worry about that. Well, so do we. We use a GlideScope Go. The problem is it's right attached to the handle of the blade. So yeah, you might not be directly visualizing the cords, but you're still down in that patient's face. So it's still good procedure to take proper protection for yourself. If you're doing aerosol generating procedures on certain patients, so droplet or airborne patients, if you're doing any sort of these procedures, you definitely want to take the proper PPE steps. CPR, CPAP, BiPAP, tracheal suctioning that's open to the air. Some people have those ventilator patients that have the closed suctioning device. That doesn't count because that's not open to the atmosphere. That's all contained. Nebulized medication administration and bag mask ventilation. Now to the spicy part. Vaccinations for healthcare providers. These are the current list of recommended vaccines for healthcare providers. Hep B, flu, MMR, varicella, Tdap, and COVID. And we're going to go through each of them and talk about what the recommendations are. Hep B, if you're working for a non-governmental agency that's governed by OSHA. It's actually an OSHA requirement that they offer it to you within 10 days of your employment. They have to say, hey, have you had a Hep B shot? Yes or no? And do you want one? That's actually a federal requirement. Has to be offered at no cost to you. And if you initially say, well, I haven't had it, and then in a year and a half change your mind, they still have to honor that request within a reasonable time period, and it still has to be offered at no cost to you. It's a 3-dose series. You take the first shot now, second shot in a month, third shot after 5 months from number 2. Ideally, you want to go 1 to 2 months after your third shot to have your titers drawn to make sure you actually do have immunity from Hep B. Some people don't actually get long-lasting immunity from it. So you want to know, was the vaccine series successful? Influenza, it's definitely recommended annually. Those of you that have worked for hospital-based entities or worked at a hospital, this is a hospital-based requirement on an annual basis unless you meet the medical exemption criteria. The formulation varies annually. It's either the trivalent or quadrivalent. The World Health Organization meets every June to try to figure out what are going to be the prevailing strains for that flu season. Then they go out and start manufacturing them, so the formulation is a little different every single year. MMR, this one's actually a little bit more complicated than some of the other ones. If you were born in 1957 or later and have not had the vaccine, or you don't have a blood test that shows you're immune to measles or mumps, so you've never had measles, mumps, you don't have prior vaccination, they'd want you to get 2 doses of MMR. The problem is, and I was in this boat as a healthcare provider, at the time when I was born and got my childhood vaccination series, they had only recommended 1 dose of MMR at that time. So actually about 10 years ago when I started flying and I went to employee health, they said, well, you've only had 1 MMR vaccine, you need a second because now they're recommending 2. So those of you that have only had 1 MMR shot, talk to your employee health, talk to your family physician. Chances are you need a second one. If you were born 1957 or later, not had the vaccine, and don't have immunity to rubella, they say you only need 1 dose to have immunity from rubella. But since it's combined within the MMR vaccine, congratulations, you're going to get 2. If you were born before 1957, you can go on the CDC's website under the American Council of Immunization Practices and look at their vaccine recommendations. Varicella, so this is chickenpox. If you have not had chickenpox as a child or teenager, and if you haven't had a varicella vaccine or a blood test that shows you're immune, recommended that you get 2 doses of varicella vaccine 4 weeks apart. So if you've had chickenpox as a child, you're going to have immunity from varicella. You don't have to worry about that. Tdap, so tetanus, diphtheria, and pertussis. Pertussis is whooping cough. This, unfortunately, is starting to make a comeback. Get a one-time dose of Tdap as soon as possible if you've never received Tdap previously. So if you just received the tetanus, diphtheria, but you didn't have the pertussis component of it, the recommendation is to go out and get one. And then once you've had at least 1 injection with pertussis formulated into that, then you can get either a traditional tetanus TD or a Tdap every 10 years thereafter. Pregnant healthcare workers, and this is actually something I didn't know until recently, they need to get a dose of Tdap during each pregnancy. So one of these things I'm going to show you here, and I'm going to see if the video works okay on here. One of the things that we're seeing, especially in West Virginia, in pockets of rural communities, is we're seeing a resurgence of childhood illnesses. And I just want everybody to make their own informed decision on this. But we know that measles is especially problematic in adolescents because it's one of the most highly infectious viruses out there. Measles, on average, for every 1 individual, they infect about 12 others. Things like COVID and Ebola are around 2 to 3. So it's extremely infectious. And you need a very, very high herd immunity rate in the community to prevent widespread transmission. That rate's around 94, 95%. So there's two examples here. The one on the left is a simulation, and this is out of the University of Pittsburgh. A 80% coverage of MMR vaccination in Mahoning County. And the one on the right is 95% vaccination coverage. Red dots are actively infectious cases and blue dots are recovered. And this goes for about 30 seconds, and it's going to simulate about 200 days of spread within Mahoning County. And you'll be able to see exactly what the problem is when the vaccine rate drops off just a little bit. Because when we think of 80%, oh, that's still really good. Not when we need 95% in order to prevent widespread transmission. So that's after 238 days of transmission. Now, mind you, that's with no public health measures in place like school closures or anything that we did really early on in COVID. But you can see there's a stark difference with just a 15% difference in vaccination rate. So if we as healthcare providers are working in this community during something like a measles outbreak, it's especially important to make sure that we're not going to get sidelined or extremely sick with measles while the rest of the community is struggling with it. Current coverage estimate for the state of Ohio, looking at MMR vaccines specifically, kind of referencing that last example to give you a little bit of hope. The current estimate is that 93.3% of children ages 13 to 7 have received their 2 doses of MMR. That confidence interval is from 89% all the way up to 96%. So we can see that there are going to be pockets amongst the state that are a little problematic with measles, mumps, and rubella, but ultimately the state has a really high vaccination rate. Now on to probably the most controversial one. I'm not going to give you my own opinion unless I say it's my own opinion. I'm going to try to stick to the facts here. Right now, there are 2 out there that are FDA approved that are both messenger RNA vaccines. There's the Pfizer vaccine, which I'm not going to try to butcher the brand name of that. And then Moderna, which has the most Marvel comic sounding name out there called Spikevax. That got approved by the FDA for full use yesterday. And then there's the viral vector that's manufactured by Janssen or Johnson & Johnson. And what that is it's a more traditional style of vaccine that uses adenovirus as a viral vector into the cell. One thing that I think is important for us to understand of EMS is how we fit in with the larger healthcare system right now. There is a CMS requirement out there that I'm sure you've seen in the news, and this is not to agree or disagree with it. This is simply to put the information out there so you're aware of it if you hear anything. It was recently upheld by the Supreme Court of the United States, requires hospitals, nursing homes, and other healthcare facilities and their vendors to require vaccination as a condition of participation in Medicare and Medicaid services. So ultimately, the government's saying if you want the money from Medicare and Medicaid, these are a condition of participation. Where it gets a little bit gray and where you're going to see a lot of probably further explanation from news sources like GEMS, EMS1, Page, Wolfberg, and Worth, other EMS legal firms, is this definition of a vendor. EMS can be considered vendors if they have a contract with a nursing home or hospital. So I'm going to use my own example here. We are a consortium-owned organization. We are owned by the 3 largest academic medical centers in the state of West Virginia, WVU Medicine, Charleston Area Medical Center, and Cabell Huntington Hospital. Since we are hospital-owned, hospital-based, and have hospital contracts, we are fully held to this standard. If I am working for a fire department in rural West Virginia that does only 911 and has no contracts with anybody, this CMS requirement means nothing to me because I'm not one of the covered entities. So you're going to see a lot of confusion in the EMS industry on who's covered under this, to what extent, and how. I'm just putting the information out there because you're probably going to see more on it. The one thing that I will tell you is my opinion alone, and does not constitute the opinion of my employer or anybody else, is just kind of food for thought. I do teach in the public health department at YSU, so I feel this is kind of like one of those civic duties just to kind of put this out there to kind of pull us back to a little bit of a middle ground. Word of cautions on where you get your information. Social media, we always told people pre-pandemic, stop WebMDing stuff. Because if you get on WebMD and say you have a headache, you're going to come out of there with a diagnosis of Ebola and a 2-hour death sentence. So avoid meme science, stick with some more reputable resources. Now, the definition of reputable is kind of laughable right now. Stick with randomized control trials, because if you're looking at 10 or 20 randomized control trials that are really, really high quality and they have results that are replicating each other in separate areas, then the chance of that being random noise in the system or just some random interference is pretty slim to none. So stick with randomized control trials. The other thing, there's a lot of people that assume just because something's correlated means there's a cause and effect there. So if I were to say every person who has touched a motor vehicle in the US has died or will die, that is an extremely true statement, but that doesn't mean that the motor vehicle is responsible for all of those deaths. Last thing, if you haven't heard of VAERS, Vaccine Adverse Event Reporting System, you're going to hear about that at some point. I just want everybody to make an informed decision about what they see out of there. Just recognize it's an open source platform. So anybody can go in there, whether it's a layperson, whether it's a physician, whether it's the homeless guy on High Street. If he has a cell phone connection to VAERS, he can go in and enter stuff. And just to show you an example of how everything isn't exactly as it seems, in 2004, an anesthesiologist submitted a report to VAERS saying that after he got his influenza vaccine, he began to grow big muscles, his skin became green, and he turned into the Incredible Hulk. And that was entered into VAERS as a side effect of the influenza vaccine in 2004 and remained there until 2008 when the CDC asked him, hey, can we take that out of there? And he said, yeah, I was just proving a point. So just take it for what it's worth. VAERS contains a lot of really good data about the prevalence of certain things, but it is an open source database. So I just ask everybody to approach things with a skeptical mind, do research from reputable sources. If you don't know, ask a lot of professionals and see what the going consensus is from well-respected professionals in the industry. And that is all I have on that. Does anybody have any questions? All right, I didn't do the full Joe Mistovich. I did a partial Joe Mistovich and only went 5 minutes over.
Hey, Justin, that thing with the contracts is exactly what I'm going through right now. And now the big thing is, what's the definition of a contract?
Mm-hmm.
So now
we
we're
tried
there. It's changed. It has changed every day for the last 4 or 5 days exactly what we're supposed to do. So,
yeah, we tried arguing that same point, and then when the hospital said we own you, that kind of took the wind out of our sails for arguing anything. So that's kind of where we were at.
Yeah. All right, everybody, we'll take a couple minute break. Let's see, it's 7:06. How about 7:10? We'll start back up.
Hey, Matt.
Yeah, go ahead.
I couldn't. I'm on the phone, driving across the turnpike. No weather yet, but I didn't get to ask a question before we went to break, and I just wondered if there was anything with a precedent being set that we're going to turn into guinea pigs. You know, this passes. Next thing that comes along, let's try it out on the EMS community or healthcare community because we kind of got them bent over a barrel, you know, with the Medicare funds.
Well, way back when, and this is Matt Gordon's opinion, not anything else.
Sure.
In one of the committees I was with the state, I won't say I accused them, but I mentioned that I felt like that they were using EMS as guinea pigs to find out what they can get away with PPE when we were having the PPE shortages. I don't want to say we're canaries or guinea pigs or anything like that, but it's such a politically charged situation that honestly, this isn't the forum for, at least not for me in this role, to be discussing, if you understand what I mean.
Absolutely. Absolutely.
Hey, Matt, it's Justin. I think I can give one little bit of insight. And yet again, I'm going to frame this from the standpoint that this is Justin Coper's own personal opinion and does not represent anybody except me. I think what you're going to find is that CMS is going to have a really hard time enacting really, really strict legislation and requirements on individuals that they do not federally govern. So, for example, CMS regulates hospitals, nursing homes, all of those things. They don't regulate the plumber coming in to fix the pipes at the nursing home, and that's what some of this legislation is attempting to do. So I think there's definitely, no matter what, going to be a legal battle one way or the other. But I think the end result is going to be a bigger definition of the scope of authority for agencies that don't have to follow CMS standards of participation.
Justin, are you suggesting that there might be a little bit of overreach by a particular part of our government?
As soon as the one from a 4-letter acronym that starts with O and ends with A came out, being an occupational safety and health guy, I'm like, there is no way that is going to stand based on how it's written.
No, we shall see.
Matt, it's Joe. Just one thing, my understanding is that EMS, if EMS is billing Medicare and Medicaid, then they're not considered a contractor. They're considered a direct provider of Medicare and Medicaid services, and they fall under the CMS mandate. We're dealing with this at Mahoney County Public Health because we do provide direct services to the public at the health department, and we do bill Medicare and Medicaid, and so therefore they are required. But as Justin, and you're saying, Matt, too, then it gets really, questionable when they say contractors, because we have a large number of contractors too. But so my understanding is anybody who is billing Medicare and Medicaid falls under the CMS mandate. Just my personal opinion as Joe Mistovich, I think unfortunately the real guinea pigs are the military members under the Department of Defense, because they really have no real leeway in their response to, you have to receive this vaccine. And I'll just say this, it's really interesting if you look at some of the data coming out of the DoD by whistleblowers. Several whistleblowers have come out who have actually worked in healthcare, with some of the numbers that they're reporting with adverse drug reactions in the form of vaccines. It's very interesting. So, but I don't know if Justin, you might correct me if I'm wrong, but my understanding though is anybody who bills Medicare or Medicaid is considered a CMS provider and falls under the mandate.
So that's the way I thought of it initially. And then when I actually read the finding from SCOTUS and the actual initial thing from CMS, they had to write it narrow enough that it only affected facilities that have to follow the CMS conditions of participation on an annual basis, i.e. CMS comes in to audit your facilities. So unless there's a specific chapter of federal regulation where a CMS inspector walks in once every 2 years to audit your facility, or every 3 years like they do at hospitals and nursing homes, it was actually pretty limited to hospitals, nursing homes, ambulatory health centers, and I think public health departments that provide service to the public, so they may be included in that. But in that legislation, they actually had to spell out every type of healthcare provider that was covered, and EMS did not appear. The only alluding to EMS was through the vendors, contractors, and agencies that provide services to patients of those facilities through a contractual agreement.
Okay, interesting. I was not aware of that. And just one other point, because I actually went through this and I actually contacted Pfizer on 2 different occasions in regard to the FDA approval. And there again, I actually read the FDA approval of the vaccines, and this is something that's actually a little bit deceptive. And again, I'm just, this is factual information, whether, I agree with it or not, it doesn't matter. But so Pfizer, was producing 2 variations of the vaccine under BioNTech label. And then they came out with the Pfizer vaccine that was FDA approved, and that was the Comirnaty. The Comirnaty is the actual FDA approved vaccine. Well, the interesting thing is the reason why FDA approval is so crucial on this is because if the vaccine is being used under emergency use authorization, nobody is liable. The drug company's not liable. The administrators aren't liable. The hospitals aren't liable. Whoever's giving the vaccines, nobody's liable as far as if there is an adverse reaction that may include death, and there's been several. Nobody could come after the drug company, the hospital, or anybody who administered the vaccine or made the vaccine. And so I'm sure this is the same with Moderna, but I don't know that for a fact. But under the Pfizer, if you go to get a vaccine, now Pfizer came out and Fauci came out and everybody came out and said, well, the Comirnaty is basically exactly the same thing as the Comirnaty, and the Comirnaty is the same thing as the BioNTech 2 formulas that they use, but it's not. I called Pfizer specifically to find that out, because reading the FDA approval, Comirnaty actually has different additives, and it actually is made under a different process than the 2 BioNTech vaccines. So unless you specifically look at that vial and that vial says Comirnaty, you are not getting an FDA approved vaccine. And I'm sure that's the same with the Moderna. And you said the trade name of the Moderna. So if for some reason you're out there saying, I only want the FDA approved, then you have to be sure that you ask for Comirnaty or the Spike, whatever it would be. The trade name that yeah, because they're claiming they're exactly the same, but they're not. And that's just a point of information, because a lot of this has to do with liability, and the onus of responsibility that right now under emergency use authorization, there is none. So unless you get the FDA approved drug.
Where that came from is actually legislation that came out after September 11th, 2001, because when they started developing the strategic national stockpile, they recognized that, hey, if we have to roll out a brand new vaccine to a weaponized Ebola, we're not going to have time to go through the traditional FDA approval process if we have 18 million doses of it in the strategic national stockpile. And we don't want 80,000 Ebola patients showing up at a hospital in 2003, because, we also thought that everybody was going to get anthrax in 2002, and that never panned out. So they panicked and wrote that piece of legislation to limit liability to manufacturers for things under EUA, especially in a pandemic and all hazards response. So that legislation is actually pretty old, but that's where that came from.
Yeah, and again, it's not that I disagree with that, but I mean, and then in my last comment, I'll be done. But if you look at the World Health Organization data too, and you are absolutely correct on the virus, it's self-reporting. So there's very limited. But one thing too is adverse reactions to the vaccine are tremendously underreported. That's the problem they're having with VAERS too. And physicians are not even reporting the adverse reactions to the vaccine. But World Health Organization published a few months ago data, and this is really interesting, that the highest vaccine adverse drug reaction before the COVID vaccine was the influenza vaccine. And in 53 years, they had like 274,000 adverse reactions reported in 53 years. COVID worldwide had reported more than 2.4 million in 1 year. So it just tells you a little bit there. But again, you have to make your own judgment. And I absolutely agree 1,000%. And this is what Larry's going to cover too, is a double-blinded study. And again, a lot of the stuff that's been put out there as pseudoscience by what we thought were reputable sources is pseudoscience to sell a product in some cases instead of truly looking at treatment. So, but anyways, Larry will clear that up in his lecture. So thank you though.
Yeah, and Joe, I agree with you fully that I think the biggest thing we need to always consider when we look at, and I'm sure Larry will cover this too, when we're looking at the raw number of X, kind of knowing the denominator to put it in context with, because I think that's one of the biggest kind of context clues when we're looking at, oh, is this bad? Is this good? Is this something to pay attention to? If it's 2.3 million out of 2.5 million, we got a really big problem. If it's 2.3 million out of 2.3 billion, not so much. So being able to establish the context, and that kind of leads right into what Larry's going to talk about.
Great. All right. Thank you, guys. Leave it to Joe to bring it on to extend that time. But he brings up good points, right? And this is what's unique about this refresher is that we can have people all over the world, actually. And I say that because Robin and Tom are joining us from Mexico today. So people all over the world via Microsoft Teams today can actually join and participate. So what I'm going to do for the next hour or so is talk about research and evidence-based guidelines in EMS. And some of this has been borrowed or at least referenced from the Pre-Hospital Guidelines Consortium. And a lot of the things that we've done before has been in practice, and just because that's how we've always done it. And I'm going to hit on a couple points that Joe and Justin talked about. But what we're doing is we're a very young profession in the healthcare world, and we need to be able to grow with everybody else. And a lot of the studies out there aren't really done in EMS because there's really no time to say, okay, patients, I'm going to select drug box B instead of drug box A and try to do some sort of double-blind study. And we'll get into what double-blind means here in a little bit. But what we're going to talk about today is, we're going to describe what evidence-based medicine or the evidence-based practices. We're going to explain the value and research in EMS. We're going to talk about the use of evidence-based guidelines, which there's actually a whole draft on the SEMSO's website. I'll put it up when I do the Google Classroom to talk about what protocols and what EMS directors should be doing. And again, one of the things that I want to remind everybody of is that the national core component for the National Registry, they actually tell us what we need to talk about, and it's up to the instructor to go and dig that information out. So, when you come into this refresher, and Matt and Joe have both told you that this is not a typical refresher where we're going to teach you your protocol, because anybody can be a monkey and be a cookbook paramedic or EMS provider and follow a set of rules, right? If you want to do that, maybe you should be a chef, because chef is, and working in the kitchen is something that you follow a set of rules specifically in order to accomplish a goal. But what we are trying to do in this refresher is we're trying to get you to think methodically. We're trying to get you to think abstractly and, use your best judgment. And you heard us throughout this refresher talk about the Trumbull Regional Medical Center protocol, because it's a guideline. And I'll put this up at the very end. But there are no arrows per se. We have all the information on a piece of paper on one page, and you use your best thoughts. You use what you learn to treat the patients. And I think you have more freedom. You can, I told you last week that you need to respect yourself as far as like, the amount of responsibility and the training that you have in order to be a better healthcare provider. And once we do that, we can evolve as a system. So we're going to talk about some guidelines. We're going to talk about how do we actually create an evidence-based guideline and then how to incorporate those. Most of these will be done on the national standard, but I just want to let you guys know that we actually talked to trauma services 2 weeks ago here at Trumbull, and we're going to involve the trauma team, and we're going to involve every provider under our protocol to do some research studies. And we're currently developing some questions and trying to get some answers on pre-hospital blood and the use of ultrasound. So that's going to be coming down the road. But we decided that in order to up our capability here at Trumbull, we need to start being involved in some of these studies. So if we knew what we were doing, it wouldn't really be called research, would it? And I think that's true because, medicine evolved. What we did in the 1800s and not necessarily what we've done in the 1900s and what we're doing now in 2022. And you see that because some of the cardiac protocols have changed. People used to give morphine because that was one of the first type of pain analgesias we used. And then it led to, well, let's go and give fentanyl because we know that with morphine, we make the blood pressure unstable and we can drop the blood pressure. And then we thought that it would, vasodilate, but maybe it didn't really do that. And we thought it would decrease the oxygen demand of the heart, but it actually increased it. And it just wasn't a very good drug. So they realized that giving morphine wasn't great for these STEMI patients. And they went to fentanyl. But guess what we're realizing now? That fentanyl inhibits the gastric absorption of an antiplatelet drug called Brilinta. And so as of yesterday or 2 days ago, Dr. Swift put a hard stop to fentanyl for all ACS protocols. So whether you're having a STEMI or whether you're having acute chest pain, the initiative is going to come down the line that at least at Trumbull, you are not to get fentanyl because it increases with, it interferes with the treatment that they might do in the cath lab or even the treatment that we're doing pre-hospitally. So we're going to talk to pharmacy and we're going to add the acetaminophen or the IV Tylenol that we talked about a couple days ago, and it's going to work. So evidence-based guidelines work really well because as patients change, as the research change, I think we need to evolve as well. And for a very long time, EMS has not done that, but it does lead to great things. And I'm very proud of the team that we have here at Trumbull. That is leading the way, I think, for Ohio. And, if the research is out there, we're doing it. And we've been very successful with Dr. Swift and Trumbull Regional Medical Center to get that done. And we've actually had different states across the nation reference our protocol. And we've been invited to sit on a couple other committees throughout the state. And we're actually talking to the Cleveland Clinic to talk about their protocol and their whole Northeast Ohio consortium up there. So we're very proud of that. But let's figure out how we get there. So again, the National Registry recognizes how much evidence-based guidelines need to go into their competency. And so that's why you've seen since about 2016, your refreshers have changed. They're not just going up and open up the Brady PowerPoints or the book PowerPoints and are just reading you a protocol and say, this is what we do. This is how we treat chest pain. We're going to give 324 of aspirin. We're going to follow it by sublingual nitroglycerin. And then, we're going to give the morphine or the fentanyl. There's actually research goes in there. And like I said earlier, that the National Registry will actually put out these guidelines to what we have to kind of teach you. And so if you haven't gone through a program that's this in depth, then, welcome, because we're glad to have you. And we're going to do things so we can re-educate you or maybe teach you something that you haven't learned before. But again, we have to ask the question, why is it evidence-based medicine and why is that important and what is it? Well, again, it's talking about, these events happen for a reason and we have to change those things. And in order to grow as a profession, we have to make sure that, we use the best practice medicine. And that could be from, the best lifting techniques all the way up to like the best IV pump, right? So it'll run through all different levels of EMS, the EMT, the AEMT, the paramedic, the critical care or flight paramedic. But we need to really figure out, are we doing the best thing for the patient? And it shouldn't be driven because of, I guess a salesperson, right? Or, people saying, well, come to this part of the protocol because, or join this part of the protocol because, this is what's great. If that protocol isn't really evidence-based driven, then are you really doing what's best for the patient? But really, how did we get here and what's going on? So we have to talk about, the compressions to ventilation ratio in CPR, right? So back prior to 2015, 2010, maybe the 2005 guidelines, we talked about 15 to 2, right? 15 compressions to 2 ventilations. And then, we did 30 to 2, right? And then the whole idea of hands-only CPR and continuous stress compressions kind of played into that. Well, the reason was because research went in because we didn't have a lot of ROSC rates, and they went in and say, okay, well, let's up the amount of compressions to ventilation and let's see what's best. And so right now the consensus is continuous stress compression is best to try to achieve the ROSC rate. And then, tourniquets were a big thing. Tourniquets originated from the military. So everybody was like, okay, great. We have all these great studies coming out from the military and they're in favor of the tourniquet. And then maybe 1, 2, or 3 different cases presented where that patient lost their limb and they contributed to that tourniquet. And so because of those 3 cases, the tourniquets were deemed bad. And so we didn't use them. But then now, the research came about and says, oh, we really need to use those tourniquets, but let's go ahead and do more research on that. And now tourniquets are one of our, our second line go-to if we can't stop the pressure or the bleeding with direct pressure. So tourniquets are a big thing, and that's why it's used in tactical medicine. That's why it's used on civilian medicine, and tourniquets are great. We know we can stop the bleeding with a tourniquet, and we can leave them on for upwards of 12 to 16 hours, and that patient doesn't lose their limb. Back in the day, and military anti-shock trousers, what they actually found out is they were doing this and they did some research on it, and they found no clinical benefits, and it actually took more time to get these trousers on these patients than it was to maybe load the patient up and go to the hospital. Same thing with fluid resuscitation, right? It used to be start 2 large bore IVs, which used to be called 14 gauge angiocath. And then now they're like, well, wait a minute. We want to have some permissive hypotension. We want to really don't start anything larger than an 18 gauge angiocath now because we were taking that to heart. And if you tell us to do something, we're going to follow that guideline. So 2 IVs, 2 large bore IVs coming into the trauma center. And, we've dumped, 2 or 3 liters of fluid in this patient. We just kind of quote unquote diluted the blood. And it wasn't good for that patient, right? We know that normal saline or 0.9% sodium chloride is actually, too much sodium to be filtered through the kidney. So we don't want to do that. And then when you think about cardiac arrest, it used to be for asystole, you would do epi-atropine. And we now took atropine out because we realized that epi is better at restarting the heart. And beryllium was used maybe instead of amiodarone. So we took that out because amiodarone was a better drug. So, those are just how our practice has changed in just those couple examples. But what if we took what we were doing now and we tried to study for the future? What we'll be doing in 10 years, right? In 2015, when Trumbull launched its protocol, we were one of the first in the country to get rid of backboards. And here we are 7 years later, and we're still having people backboard patients. So why is it that the evidence says not to backboard, but now we're still seeing patients come into trauma centers or come into the ER on a backboard? Is it because the evidence isn't there? Well, no, it's cited in every alphabet soup magazine that you can think of or journal you can think of. It's because sometimes the EMS provider doesn't believe it. They don't believe the guidelines, and that's a stigma that we have to change, right? If everybody tells you that it's not beneficial for the patient, and it's supported by the American College of Surgeons, it's supported by the American College of Emergency Physicians, and your medical director says, hey, no more backboard, guys, don't do it, don't waste your time, then, why is that provider having their judgment or their opinion overriding all the scientific evidence? And that's something that I kind of want you to kind of keep with you throughout this lecture is that, what we're telling you, and it's all backed up by science, and we need to make sure we're doing the right thing for the patients. And, I think things we do kind of we're our own enemy because we do things to go back, backwards in time instead of moving forward. So what were the previous protocols based on, right? They're based on maybe, before evidence-based medicine. Maybe it was the doctor who had good success with, let's say, congestive heart failure, and they want to give morphine and Lasix. Well, we know that morphine and Lasix aren't very good for the kidneys, and it does more harm than good because, if you have congestive heart failure, you're not perfusing your kidneys. And so what's happening is you're having the increase of what we said RAS, right? We said the renin-angiotensin-aldosterone system from the previous lecture. We had the release of epi and norepi. And then now we're going to, you're vasoconstricting the blood supply to the kidneys. And we want to dump more fluid on there. And we want to put morphine in there, and we want to put Lasix. Well, Lasix causes the kidneys to work more, right? So it causes the increased reabsorption of the loop of Henle. And so now this kidney has to try to get rid of all that extra fluid, but it's not being perfused correctly. So maybe it was the doctor's opinion that says, I had great success with Lasix. I don't want to change from Lasix. I remember back in the day when I went to a protocol meeting and I said, we need to give pain meds for abdominal pain. And I was looked at like I had like a red nose on my face and like a clown, and be like, why would you want to do that, Larry? And I said, because these patients need to be managed. I don't want to, fentanyl is a safe drug. Well, that's going to mask the exam, but it doesn't. So, I've experienced the resistance, and I think we need to, we all need to kind of just listen to the science and move forward with it. So we did have some good things that changed, right? We got rid of backboards. We got rid of morphine. We know that Lasix isn't good for pre-hospital CHF. But we did that because we had to find studies and we moved forward on them. And that's where a good protocol system and a good protocol development team is good. Hopefully that you guys can take this and go back to your respective protocol medical directors and say, hey, let's look at this stuff. Let's dig deeper into it. Just like we convinced Dr. Swift that fentanyl was a bad idea. He's like, you know what, guys, you guys are right. We're taking it out and no more fentanyl for chest pain. So how does it get started? Usually somebody asks the question, and in that protocol committee meeting, I raised my hand and I said, hey, why don't we give pain meds for abdominal pain, right? And so that started the conversation. But usually, somebody wants to ask why we're not doing something. Is there a better way we can do that? What if we could do this? How come this? Or like the new trend is head up CPR. Hey, I saw this article in GEMS and EMS world about, elevating the head during CPR and has increased ROS rates. Can we try to do that? That's all great. And that's what you guys need to be asking yourself, and take those to your EMS managers, to the protocol team, and say, look, can we get this done? So when that happens, either somebody continues to do what they've been doing, says, nah, Larry, I don't want to change. I don't want to give pain meds for abdominal pain. Or somebody listens to, you know what, let's try this, right? So things change because somebody wanted to try something new. They changed their practice. For me, I actually found the research article about fentanyl and abdominal pain, and I shared it with the committee and with the doc. And then he said, okay, cool, let's do it. And then that affected change in the whole region, right? So, and that's what's great about this, is that somebody had the courage to deviate off of the norm and said, let's see what's going on and let's do this. And we were doing that back in 2015 when we got rid of backboard. And when we first went to the level 1 trauma center here in the area, which is St. Elizabeth Hospital, they're like, where's the backboard? And they would put a patient on a backboard, and we're like, no. So we educated them, and now they don't expect the backboard, which is cool. We were able to affect that change at the level 1 trauma center. But then when you get that provider who comes in with a backboarded patient for no reason other than, oh, I backboarded them. Well, did you need to carry them down a hill? No, I just backboarded them. Now they're like, what the hell? Why are you doing this? So, to be able to affect change is great, but we can inspire others, and that's what the evidence-based medicine does. And, I keep talking about backboards, because there are providers out there who continue to backboard patients. Like, well, what's the matter? I backboard the patients. Well, because, we learned that decubitus ulcers can set in less than 10 minutes. We learned that, by simply putting on a C-collar, we increase the intracranial pressure. We learned that by restricting the chest wall with the straps that the patient can't take a deep breath. We learned all these things, but then the EMS provider is still like, but so what? I've been doing it forever, and I'm going to continue to do it. We got to kind of educate those people. We got to motivate, and we have to be that cheerleader for that one resisting person in that group of people in order to do it. I told Matt I was going to bring this up, so I am. That he and I were in the EMS room. We were working on protocol development about backboards, and an ambulance, brought in a patient on a backboard the day before, and everybody's like, well, why'd you do it? Well, he got thrown off of a motorcycle. Okay, but why'd you backboard him? Did you have to carry him? No, he just got thrown off a motorcycle. So we said, well, so what? Yeah, but that's what you're supposed to do. Well, no, it's not. And this was just last year, so let's take 6 years, right? 6 years ago, it changed. So then we took that question, and as people came into the EMS room, we said, hey, you, come over here. Would you backboard a patient if they got thrown off a motorcycle? And somebody said, yes. And we said, well, why would you do that? Because that's what you're supposed to do. All right. Second person comes in. Would you backboard somebody who got thrown off a motorcycle? Well, it depends. What's it depend on? Neurological deficit. No, it doesn't. This is why we don't. Third person. Would you backboard somebody if they got thrown off a motorcycle? It changes every month. And we're like, what? It's been the same since 2015. And we said, one more person. Would you backboard somebody? And they said, well, I'm not really sure. And then, they looked at us and said, well, maybe we should do a better job educating. Well, the thing is that, we do these educations and if it's on our fault, if it's the protocol committee's fault or that medical director's fault, and, maybe we do need to do a better job educating. But when you have people who, don't really take the time to read the protocol or don't really influence change or embrace the change, then we're never going to grow as a system and as a profession. And, I like this cartoon because they're like, oh, well, so at least we won't aspirate, right? So just know that what we're recommending and what most of the places, at least around our immediate area, are recommending are the best practices. And so we got to talk about what the current EMS care is based on. And so that's usually developed by EMS protocols, whether that's locally, regionally, or statewide. And we're very fortunate in Ohio that we don't have a statewide protocol because we have the reign to do what we're doing. Just what I said 2 days ago, yesterday, that there was a hard stop on fentanyl because of the adverse effect with Brilinta. Maybe they're done by EMS guidelines, right? Maybe that somebody actually took the time and they looked at this in the SEMSO EMS education model here, and they said, you know what, we're going to change our protocol because this is what the evidence says. Or maybe they're recommending, the American Heart Association is recommending now we're going to do 200 compressions at a rate of, at a depth of 2 inches, right? So that's, we're already following evidence base, right? Every 2 years, every 3 years, we get ACLS, we get BLS, we get PALS, we get our trauma certification. Those are evidence-based guidelines. And whether you look at them like that or not, we're already following the science. And we will absolutely always adhere to BLS, ACLS, PALS, ITLS, PHLS. But why is it that we don't necessarily always adhere to the protocol when it is based on evidence, right? So, and then, you have these, like Justin was talking about NHTSA, you have all these studies done by all these grants and stuff like that. It says, hey, maybe you shouldn't put the car seat in laterally moving ambulance on the bench seat. Maybe you should strap it to the clots. So all these people come together to give you the current stuff. And I think it's worth mentioning that, if your protocol is doing something that you think is old, again, go over to the SEMSO website, look at the current model guidelines, and maybe go back to the protocol team and say, hey, can we change this based on this? And do your own research. Again, I had said that Ohio is fortunate because we don't have a statewide protocol, but there are some states that do, like West Virginia and Pennsylvania, and we have people on the call from those places. So I want to just mention that the BLS care for West Virginia and Pennsylvania seem to be pretty aggressive, right? But when it comes to ALS care or maybe medication, they're not so aggressive. They're very restrictive. Then you have a state like Ohio, and Ohio has a model guideline. So you can go to the Ohio EMS Department of EMS, and you can look at the Ohio Adult and Pediatric guidelines, and that's what they are. They're for places that don't necessarily have their own full protocol team, and they can adopt the state guidelines, so at least they have some sort of protocol to use until they get that established. And there's only about a quarter of the states out there that don't have any guidelines, that don't have any protocol. It's those places are kind of doing some of the forward thinking, and it's okay to share information. Like I referenced Montgomery County, Texas, and some of the other places, Wake County EMS, New Hanover County EMS. You reference people who are doing great things, and you're able to add your own contribution to that. So again, in the past, these protocols and guidelines may have come from an opinion, but now we're really focused on, maybe instead of just an opinion of a local doctor, we need to talk about the expert opinion, right? Maybe instead of doctor in the ER of hospital X, we want to talk to a doctor who's the chair of the American College of Emergency Physicians, right? Maybe we also want to talk to the stakeholders such as the American Heart Association or the CDC. Maybe we want to do our own research of studies or review the current research that's out there. Maybe we want to reference those NSEMSO guidelines in order to make a protocol better. And then when you do all of that, you need to look at these studies, which we're going to get into different types of studies here in a little bit. And you need to ask yourself, well, what was the confidence interval, right? When we talk about confidence interval, that means that we usually base it off a 95% confidence interval. So if we say something has a 95% confidence interval that's greater than 1, that means that it is good, solid evidence, right? And when we talk about a p-value less than 0.05 means that is statistically significant. So when you are looking, I didn't really put those in this presentation, but if you're looking at something and you're reading an article and you find the confidence interval greater than 1 and you find a p-value of less than 0.05, you can really trust that study to say that it's pretty significant, right? So, you know, I encourage everybody to start picking up GEMS and maybe knowledge of emergency medicine and start looking at some of these studies, because what's done in the ER usually trickles down into EMS. We talked about how some protocols have, or how some states have statewide protocols, some have models and some have no guidance at all. But what's the issue in that, right? What's the issue in the variability of EMS care? Well, we know that right here in Northeast Ohio, that we can cross over the border to Pennsylvania. And so when we take a patient over to Pennsylvania, that nurse might not be familiar with ketamine. And so the nurse, like, you gave ketamine or fentanyl for what? Well, yeah, we did that, right? So, you know, at least within our own state, we can say, I know that ambulance company X and fire department company Z is going to be giving drug A for chest pain, right? So we know that there's a uniformity in care, and we can have the hospitals prepare for that. And I've already kind of told you some of the challenges of incorporating that evidence in a practice, but what we need to do is present that practice to the EMS professionals and say, look, this is why we're taking out backboards. You know, this is the leading cause. You have increased intracranial pressure. You lay the patient down. Now you have that C-collar on. You lay them flat. The intracranial pressure increases again. You put those straps on. You can't breathe. So we just got to educate them, right? Again, be that cheerleader for that patient. And then finally, you know, what's the issue for us is we can't really measure that, right? We can't continue to measure or do any studies with backboards if we get those cowboys who don't adhere to the protocol, rather, or to the evidence-based guidelines, who continue to backboard. So we can't measure anything, right? We can't measure, hey, a patient coming in with a C-collar with the head elevated 30 degrees has an intracranial pressure of what? Measured by the ICU team, right? So if everybody's on the same page, then we can actually move forward and do a lot more data reporting, and we can actually progress EMS as a whole profession. So in order for these to work, we got to integrate the best available research findings, right? We want to consider all the expertise and judgment from all the journals and from everybody that's out there that has a stake in it. And, you know, we got to figure out what's the patient's preference and what's the clinician's preference. You know, a big thing was we talk about, you know, benzodiazepines for seizures, right? And so the Rampart study says, well, I know that I can convert that seizure to a post-ictal state if I give midazolam, Versed, 10 milligrams IM, versus trying to start an IV and give, you know, 5 milligrams of Valium. Well, okay, so we talk to the patients, and in a seizure patient, they don't care because they're seizing. But if you then start to talk to the EMS providers and say, hey, what did you like better? Did you like giving an IM injection of Versed versus trying to start an IV on a patient who's seizing? See what they say. I'm going to probably guess that most of the EMS clinicians will say, oh man, I like giving an IM injection way better than trying to start an IV, right? And that was one of the pretenses for the IOs back in the 2015 guidelines, was it's probably easier to start an IO than it is to try to find a vein in somebody who's in cardiac arrest or cardiovascular collapse. So talking to the clinicians and the patients at the same time when we talk about drugs is great. And we can actually help them be part of the evidence-based guidelines by asking everybody who's involved. But one of the things we don't really want to solely base it on is that personal experience, right? And that patient or that EMS provider who says, well, this is how we've always done it. Okay, great. But being in EMS for 20 years doesn't make you good. It just makes you old. So we need to make sure that we're conforming to the guidelines. We're doing everything we need to do to be progressive, and also do what's best for the patient. So the evidence-based guidelines also aim to improve the medical decisions, right, and the quality of care. So if I told you that within 5 minutes that I want to give aspirin to all chest pain patients, you're going to say, okay, cool. But now I tell you that I want you to give aspirin to all chest pain patients with a history of, without a history of GERD. Well, we really can't do that because, what's more beneficial? We know that aspirin, the benefit of aspirin outweighs the risk for acid reflux or some sort of like maybe ulcer disease the patient has. But we want to make sure that when we do this, we're saying, hey, all patients, regardless of history, with the exception of anaphylaxis to aspirin, gets aspirin with chest pain, right? So we got to be very, very concise in how we give these guidelines out there. And we want to make sure that it's going to be for the best patient to improve those clinical outcomes, right? We have to improve the satisfaction of clinicians because we as EMS, if we feel like we fail, we're going to beat ourselves up over it. But if we feel like we did something in the patient's best interest, hey, I got that tube, the patient, I got ROSC because I got that ET tube, you feel pretty proud about yourself. So we need to make sure that we have some satisfaction in the evidence-based guidelines as well. And then also we need to be consistent, right? We need to be consistent amongst the whole thing. So, what's good at fire department A should also be good at fire department B, and the whole region should be working together because we only have a certain amount of hospitals. So we need to make sure that everybody is on the same page and the hospitals know what to expect. And just because you have protocol A or protocol B shouldn't be really deviating from the standard of care or the evidence-based guideline that is in the patient's best interest. I hit on this already, but again, we do evidence-based guidelines and practices all the time. We have the American Heart Association, the 2020 guidelines, and if you haven't recerted, you will be very soon, whether it's BLS, PALS, or ACLS, and that tells you what you should do, right? And we follow that almost to a T. We also have, Captain Obsidnik talked about the field triage and trauma triage and mass casualty incidents. The CDC put that out in 2011. And it hasn't been revised since because that's scientific evidence that says that if a patient is not breathing, and we're going to mark them black. Right? We're going to move on to the next patient who we can do more help for. So we practice it with these alphabet soup cards, but we don't really practice it with our protocol. And I'm just kind of perplexed as to why we don't do that. But when you do have a progressive system, and I keep saying that, we can actually embrace change. And we can, go for that licensure. We can go for more pay. We can go for more respect amongst the healthcare team. So there's a couple, practices that have already been in place because of these evidence-based guidelines. One of them was published in 2014 on evidence-based pre-hospital guideline for external hemorrhage control. And we do this, right? This guideline from the American College of Surgeons says that with a hemorrhage, if you cannot have direct pressure, go to a tourniquet. And if we are unable to do a tourniquet for whatever reason, let's say it's in the core, let's say, it's somewhere in midline, then we do hemostatic dressing. And that's something we do already. We know to do that because of these evidence-based guidelines. We know that, hey, I'm going to do direct pressure. That doesn't work. I do a tourniquet. That doesn't work. I can't do it. I'm going to do hemostatic dressing. We do it all the time. And that's something from 2014. But because of this research, we're able to put it into practice. Another study was evidence-based guidelines for pediatric pre-hospital seizure management using the grade methodology. And we're going to talk about what the grade methodology is here in a little bit as well. But what this study said, also published in 2014, it says that, one, we want to do a capillary blood glucose sample from poking the finger. And what we also want to do is we want to give intranasal, intramuscular, or buccal benzodiazepines over rectal benzodiazepine. Because prior to this, if we couldn't get an IV, we're supposed to give Valium rectally, right? But this study came out and says, no, look, the rectal route doesn't work. We want to make sure we give it IM. We want to make sure we give it buccal. We want to make sure we give it intranasally. And when you remember from the pain management lecture, I kind of showed a couple of the evidence bases where they recommend intranasal fentanyl over top of, IM or anything with a needle for a kid, so you don't sensitize that patient to those needles. And then another one, which I'm sure Justin's going to hit on when he talks about the helicopter utilization in February, is when do you call for a helicopter, right? And so we do things already that's evidence-based, whether we look at it like it's evidence-based, but those guidelines are there. And those guidelines are for our benefit and, again, the patient's benefit. But there needs to be more evidence-based medicine in EMS. Most of everything we've done has come from the emergency rooms, has come from the ICU, has come from internal medicine, has come from cardiology. We really don't get a lot of chances to do studies in EMS. And so when we do get an opportunity to do it, we're really ecstatic. There are great presentations and studies about blood pre-hospitally. Texas has been doing it. Arkansas, I believe, has started to do it. That's where video laryngoscopy came from, from the OR, right? And it made its way to EMS. But, everybody gets excited about the latest treatments, but is it evidence-based, right? Prior to the cardiac arrest lecture that you learned here, we talked about heads-up CPR. But did you know that 2.4 minutes was the optimal time to elevate that head prior to the lecture? Maybe, maybe not. But if we were to go ahead and just elevate the head of the clot 30 degrees right away with cardiac arrest, we know now that doing that causes the patient more harm, and we don't see that increase from morale. So in 2012, the National EMS Advisory Council actually formed some recommendations, and that's kind of where most of this is stemmed from, right? They first say that we need to form relationships with the stakeholders, and that's where your CDC, your American College of Emergency and Surgeons come from, your International Trauma Life Support, your PHTLS, your NAMT, and your AHA come together with EMS, and they say, look, let's get together, let's do some studies, right? And then number 2 is highlighted because we need to incorporate evidence-based guidelines in the EMS education, which is what this whole National Core Competency Program has been about. What are the current guidelines and trends, and let's teach them to you. They also said that they should develop strategies for defining outcomes, training EMS researchers, and create funding. Anybody who's applied for an Ohio EMS grant knows that part of the training money out there is for research and grants, not always just for EMS equipment, and because they want to be part of that as well. So they want to say, what can we do to make EMS better? And that's where all this comes from. So you should have a training for excellence, based on the EMS evidence-based guidelines. You should create a registry of current evidence-based efforts. And later on in the presentation, I'm going to show you that the University of Dalhousie in Nova Scotia, Canada, actually has almost any EMS practice that's out there. They show you the evidence-based guidelines for example, spinal mobilization, right? They talk about TXA for nosebleed, which is pretty cool. So you can go and you can research that, and that's where those databases come into effect at. We also want to make sure that we have federal incorporation into this, like the National Highway Transportation Safety Administration, like Justin talked about. How do we figure out that the car seat needs to go, front-facing, rear-facing, and not side-facing? Well, we did it because of grants in the federal highway. And it does such a great job of trying to bring these guidelines down to us, right? And then we also need to have some evidence-based scientific assemblies and workshops that we can actually sit down. And actually on the 2nd and 4th Tuesday at Trumbull, we actually invite anybody who wants to be part of it to be part of our protocol committee, where we're actually able to sit down, decipher through evidence and research articles and see how we can apply them to EMS and make one of the best protocols in the States and maybe the country. And we have a lot of networking too, right? So Dan Batesy from Vermont, he likes some of our stuff, so he's going to take that back to Vermont. So whatever we can get from everybody else, we're trying to improve EMS as a whole and not necessarily just, in the Mahoning Valley. I talked about we needed some federal guidance on this too. So in 2013, the Federal Interagency Committee on EMS also put out a strategic plan, right? And they pretty much said that we need to be data-driven and it needs to go into our EMS systems back in 2013. So in 2015 with Trumbull, that's where we said, you know what? We're no longer using D50. We're going to D10. We're no longer using morphine and Lasix for CHF. We're going to nitro paste, and we're going to CPAP. And then let me take that one step forward. In 2021, we said, we're not using nitro paste anymore. We're not using sublingual nitro tabs anymore. We're using IV 1 milligram IV nitro 1 milligram IV nitroglycerin as a push dose with CPAP, so we don't have to break that seal. because the evidence shows that if we break that seal, it takes 1 to 5 minutes to reestablish a PEEP in the alveoli in order to displace that fluid. So again, we're very evidence-based, and I'm very proud of that, and the job that Matt and Dr. Switz have done to move everybody else forward. And that's what we're doing. We're adhering to this goal very strongly. The objective 2.1 is we have to support the development and implementation of these evidence-based guidelines in according to the pre-hospital model process. And so there's a whole package on how do you implement evidence-based guidelines. And so we're doing that at the local level, and we hope to affect big change at the state and regional level as well. But again, we also need to form those relationships with everybody who's involved in order to present the scientific evidence to make things work. I had hit on that there's not a lot of pre-hospital research that's done. Normally, most of everything comes from other studies in the ER, in the OR, in the cath lab. But we definitely need to make sure that we're part of that, and that's what we're trying to do here at Trumbull. But again, you have Canada and the United States with the Resuscitation Outcomes Consortium talking about CPR, right? They're talking about all these studies and say what is best for the patient, and that's how we figured out the depth for 2 inches of CPR. That's how we moved from 15 to 2 to 30 to 2 for compressions to now continuous. That's how we know that the electrical phase was in the first, less than 8 minutes, right? We have to do focus on defibrillation versus going straight to CPR first. And that's where we know that amiodarone is now equivalent to lidocaine for VFib, VTAC without a fault. So all these people are invested in trying to get the best outcome, and we really need to embrace that. And then one of my favorites is like the neurological emergencies treatment trials, which is very similar to the Rampart study. They said, do we want to use IV Ativan or intramuscular Versed for seizures? And so these patients, these EMS providers, what they would do is they would grab their drug boxes and they would just get a random drug box. Maybe one is labeled an odd number and one is labeled an even number. So all the odd numbers at the beginning of your shift would be assigned to these random units, and all the even numbers would be assigned to different random units. And so they didn't have a choice to say, I'm going to pick up the Ativan instead of the Versed. They actually didn't have the Versed in their box, and they had to start an IV and give the Ativan in order to terminate the seizure. And the same thing happened with the other group. They only had Versed on board, and they had to terminate the seizure with the Versed intramuscularly versus the Ativan IV. And that's where these guidelines come from, right? So, when you have the EMS person not knowing what the drug is that they're giving, let's say I'm going to take out box 1 today, and I'm going to have a vial of this, and all I know is I have to give it IV, then that's kind of blinded. Like, I don't know what the drug is. I know I have to give it this way, but I'm not sure what I'm giving, but I know it's safe to give. That's a blind study because the EMS professional does not have that knowledge of what they're doing. They just know that they have to perform this certain way with this certain drug. And when the researcher doesn't know what it is, that's called a double-blind study. So the researcher doesn't have any idea which box is which, and they don't know which drug is in which box. So they're blinded, and the EMS provider is blinded, and so that's where you get some of the best research, like Joe and Justin said. This is the little snippet of the website that I was talking about, Dalhousie University in Nova Scotia. And so they do a lot of pre-hospital emergency care deciphering of data. And so I would encourage you to look at that link that I posted when I post these up onto the Google Classroom and just take a look at some of this stuff. But one of the things I kind of want to, key your attention to is this was reviewed in 2016. And so here, what we see that they've actually collected all the data on spinal injury. And so you can see what's supportive in green, what's neutral where they don't take a stance in yellow, and what it's against, right? So what they're supportive of, going back to our backboard talk, is they're supportive of inline stabilization for intubation. Well, we know that, right? We know that we don't want to kind of move the head if we're trying to intubate somebody with a spinal injury. But they also say that, let's talk about C-spine clearance. Maybe we'll do a scoop stretcher, and then maybe a self-extrication. So let's go to a car accident. Somebody is T-boned, let's not use T-bone. Somebody has a front head-to-head collision on a car accident, and we get there. What do we traditionally do in the past, right? you had the first responder who came, they got on the back seat and they put both hands on the patient's head and they held, I got inline stabilization. Cool. You had somebody else apply the seat collar. And then from the outside, you had somebody tilt the patient's body downwards towards their left shoulder. You had somebody else twist the spine so that their legs are still in place, but now you got their shoulders almost parallel with the ground. And then you had somebody pick up the feet and twist them, and you slid them out onto a backboard. Imagine how much harm we did to the spine not knowing it when we put somebody like a pretzel and try to shove them out of the car. But now what they're saying is, you know what, sir, let me put a collar on you. Can you get up and get out of the car on your own? Yes. And that's what we do. That's what we do now. But to say this 10 years ago was like, oh man, you're crazy, Larry. I would never do that. You're going to cause a spinal cord injury. Well, no. And if you listen to Joe's lecture, we know that the damage is pretty much already done. And when you do a full assessment, you look at myotomes, dermatomes, can you feel me touching? Do you feel pain? We know that the spinal cord is intact. So that's that. But one of the things I want to draw your attention to is that big yellow arrow over there is they advise against the long spine immobilization device, which is the backboard. And again, this is in 2016. We put it in 2015. And yet in 2021, last year, we still have patients bringing them on the backboard. And just last week, I responded to a call, and the first responding agency had the patient on a backboard with head blocks and straps, 3 straps along the backboard, and they had a head strap and they had a chin strap, like ready to go, Larry. I'm like, what the hell did you do? Like, we use a backboard. Why did you use a backboard? Well, the patient passed out. Okay, why did you use the backboard? Well, the patient passed out. It's a neurological deficit. Well, no, that's not it. That's not how this works anymore. So I pulled the captain off to the side. I said, hey, look, who's your protocol under? He told me who the protocol was under. I said, look, it doesn't work that way anymore. Thank you for doing what you did, but maybe next time, you don't need, just put a seat collar on them. And he's like, oh, really? I said, yeah. I said, look, I'd be happy to explain it to you. I said, let's just take the patient and we'll come back and we'll talk. And that's what we did, right? So, but again, backboards are not recommended nationally, internationally, at least in Canada. And, I looked up the NASEMSO guidelines that are the draft guidelines that are out there as of August 2021, and they do not recommend the use of long backboard, which is pretty significant because PHLS and ITLS, they didn't really take a stance. They said it's strong evidence to suggest the use of backboards is detrimental, or not recommended rather. But now the NASEMSO guidelines are good. They've taken a stance that says, look, based on evidence, we don't want you to use the long backboard routinely. Now, if you have a patient in the mud, you got to carry them across train track, whatever you need to do, then you do it. And usually once they're on the backboard, you just kind of leave them on the backboard and take them to the hospital. But that shouldn't really be our train of thought anymore. This is a really good database. I encourage everybody to look at it. Again, one of the things that I found in here is we've already implemented into our 2022 protocol that we're about to release is TXA for nosebleeds, right? So there's a bunch of evidence to say squirts atomize with a mucosal atomizer, like you would give Narcan up the nose. Go ahead and give some TXA up the nose and see if you can stop that nosebleed. What they did not take a stance for is leaning the patient forward. So great stuff in that database. I encourage you to look at it. And the cool thing is they cite all the studies that they've got this evidence and this data collection from. So cool things there. We're going to reference it as long as it's up and it's current. But again, change has to happen. And if you're instrumental in your protocol and your EMS system or your fire department, take a look and let's see if we can affect change for the whole area. We know, again, I've already talked about trauma triage, right? We know what's green, what's yellow, what's red, what's black. And no longer is it really that intrusion into that car, or is it because airbag deployments or because the car rolled over? It's more, because of how the patient's presenting. In the cardiac arrest lecture, we talked about bystander CPR, early defibrillation is what's actually driving ROSC throughout most of the country and almost internationally. We just talked about the use of tourniquets, how they were in favor, then somebody said they weren't really good, and they took that clinician's word for it, and that nobody used them, and then they got re-implemented. And, things such as like the cath lab too, right? So if I do a pre-hospital ECG and I send it to the cath lab or I send it to the ER doc, now the cath lab is already activated. And if it's after hours, maybe they call them a second team if there's already somebody there. but that's great stuff, right? And that's all driven by data. We know we can transmit it faster. We get the cath lab there. We had decreased that door to balloon time. The patient survives, and that's what the evidence is all about. Again, we've already been doing it, maybe not the way that we thought, but again, the AHA, the CDC, all the PALS, the BLS, we're doing it, and now let's just make sure that we're doing it with what our protocol says. And again, let's make sure that the protocol is evidence-based. So how do we do research, right? Well, if you remember back in maybe 5th or 6th grade, maybe 7th, 8th grade, junior high, you learned about the scientific method, right? And that scientific method said, well, let's ask a question. Let's ask a question, let's look at the literature, or let's perform the experiments, right, to seek the answers based on a hypothesis, right? Then we're going to test that hypothesis. And then we're going to analyze the data or the reports in order to see if we proved our hypothesis correct or incorrect. We're going to then make a report, and that was the worst part about these science fair projects, is that we had to make a report, a big poster board, and we had to report that. And then we had to either refine that hypothesis and go back to the drawing board, or we had to nullify that. But for researchers, they might have to adjust their question, and that's how it's done, and that's how we get to where we are today. So there's quantitative research, and then there's qualitative research. With quantitative research, using the scientific method, we can usually measure something, right? We usually have statistical analysis that we can say, hey, I know with certainty that this is, the p-value is less than 0.05. So I know that this is statistically significant. I know that a confidence interval, 95% confidence interval greater than 1, is showing that this did not happen by chance, right? So when they do that, they can measure that. And there's a whole different there's a whole, course you can take on statistics. And if you've ever taken it, you wanted to gouge your eyeballs out, maybe kind of like this lecture that I'm giving you. But, it's important to know, because you got to figure out how we get there. I keep saying, where were we and how do we get to where we're going? So research can be two things. They can be prospective, right, which is looking towards the future. And those are usually those randomized clinical trials that Justin and Joe mentioned. Here, they're usually blinded, and they just randomly select, okay, for this patient, we're going to use this drug in this box. We don't know what this drug is. We're going to use this drug. And then that's a blind study again, and we're going to see how the patient responds to that, and we're going to report that. But then there's also a retrospective study. Retro means going back. And so we got to go back in time, and we kind of look at, a thing today was about, I talked to Matt, and he was talking about, STEMIs that the EMS people brought in, and they were looking at time, right? So door to balloon time, first medical contact to aspirin, first medical contact to EKG. That's all times we're using with existing PCRs that we can go back and we can look, and that's going to drive the outcome of that patient. So maybe we need to go back to the drawing board and say, look, we need to educate these people on how quickly we give them aspirin, how quickly we get the EKG done, how quickly we transmit that. So we go back and we look at data, right? And then we use that data. Let's just take the PCR. We use the times on that PCR to guide our protocol. And if you've seen our new protocol, we have a little clock symbol in there. We usually say, hey, try to get aspirin on board within 3 minutes of first medical contact for chest pain. Try to get that EKG within 5 minutes of that chest pain. Try to be en route to the hospital within 10 minutes of arriving on scene. And again, activate the cath lab as soon as possible, right? And that's how we implement that stuff into our local protocols based on PCR reports. But then sometimes, we can't measure something, and sometimes they're just observational studies. And that's called qualitative research. And so with that, we describe the research there. And usually that's best for generating questions and explaining concepts when we can't measure it, like I said. So again, why do EMS providers choose to do things a certain way? Why did those 4 or 5 EMS providers that we kind of randomly pulled in the EMS room, why did they all say you should backboard somebody, right? And they all had their own reason. And we just took that and we went out with it. And again, I think during this refresher, for those who were in that EMS room and they're on this refresher, now they know that they shouldn't do that, and they know why they shouldn't do that, right? So again, that's qualitative research. So there's different types of case studies here, right? And so, research studies. So when we talk about case studies, one of the things that, somebody told me that Lane Life Trans actually had a couple of days ago, or maybe a couple of weeks ago, was they had a pediatric patient who had a stroke. And that's something really don't see a lot in EMS. And, that patient, it wasn't new to that patient or that family who had the stroke, but it may be new to that EMS provider. So when that EMS provider comes to the table and they present it to medical direction or their EMS supervisor and they say, hey, I have this patient, and the patient was, I don't know, under 10 years old, and the patient had a stroke. And that's pretty interesting because I've never seen that. And they decided to write a paper on it. That's called a case study, right? It's something we don't see a lot of, but it's interesting enough to kind of write that study and see how things and follow that patient up the treatment course. But if you're conducting that research and you're not looking at a certain type of patient, another way to look at it is I did something and it worked or it didn't work, right? So that's that. When you have a bunch of things that you're doing together, let's say now that pediatric stroke, we say in the county of Trumbull County, Ohio, there were 4 pediatric patients under the age of 10 who all had strokes. Now you have a series, you have a group of people meeting a certain definition that are having the same presenting symptom. And now you need to maybe investigate a little bit more, but now you can write up a paper based on those 4, 5, 6 patients who had that pediatric stroke. And maybe now you can dig a little bit deeper and you can say, what were the common factors with that patient or those patients that had it? Was it that they all got water from water source A? Was it that they all had, houses that were built prior to 1969? Whatever it is, you can now try to extrapolate some data, and you can try to figure out why all these patients in Trumbull County under the age of 10 had strokes. So that's a case series. Or another way to look at it is I did something a bunch of times and it either worked or didn't, right? When we talk about cohort studies, that's something with common characteristics and identify factors related to developing a disease or outcome. So again, I kind of told you about Trumbull County and the pediatric patients who might be having a stroke. But once you start to investigate, okay, I have 4 patients in Trumbull County under the age of 10 years old who presented with stroke-like symptoms. And group A lived in a house that was built before 1969, and group B lived in houses that were built after 1969, right? So we can kind of look at that, and that's called a cohort study. So there's also case control studies where we kind of look at the outcome intervention compared to the controls, and then randomized control studies where we don't know what's going on. The EMS clinician doesn't know what's going on. They just know that they have to do something and they're going to have an outcome and they're going to be measured, right? So when we talk about this, I'm going to give you an example, right? So, but here's just a little way to look at it. So a case control study, right, will compare the risk factor frequency, the cases of people who have it, to the controls, right? So there's quite a few studies out there about, since COVID hit, let's just say in the ICU, right? So in the ICU, everybody had COVID. And so if you were to do a case control study about COVID, you would want to do the nurses entering that ICU ward and see how many of those nurses got COVID, right? So what was the control though? How many of those nurses got COVID-19 based on their patient interaction? And so you would say, how many wore the N95 mask, donned the PPE gown, and washed their hands afterwards? Okay. So you would say 1 out of 20 nurses got COVID-19 based on all the recommended guidelines with an N95 and with the PPE gown and with washing your hands, right? But then the nurses who didn't wash their hands, actually 19 of them got COVID-19. So that's where we kind of control that, right? That's called a case control. Retrospective cohort is another one, and this is going to be applied to EMS here. So let's say that we're transporting a patient who has COVID-19, and let's say, okay, of all EMS providers here in Northeast Ohio, or who is on this call tonight, of those who are transporting COVID-19 patients, how many of the EMS providers contracted COVID-19, gave an aerosol or nebulizer treatment in the back of an ambulance versus those who did not give a nebulizer treatment and treated with mag sulfate? And so that retrospective, you go back, you look at the EPCR, you look at that and say, oh man, I see 80% of the EMS providers who contracted COVID got it in the back of an ambulance because they give a nebulizer treatment, right? But then the other people did not contract it because they did not give a nebulizer treatment. They gave mag sulfate. So that's a retrospective. We go back in time, we look at what happened, we compare how many people got the disease, which is also known as the incident, to what was a risk factor. And in that course, it was, in that example, the risk factor was aerosolizing or nebulizing a COVID-19 patient. So with prospective cohorts, we can look forward, right? We want to say, what's the risk factor moving forward to how many people get the disease? And then a clinical trial, the randomized clinical trial, that's actually most scientific, as we've talked about. So 2 go backwards in time, that's your case control and your retrospective cohort, and 2 can actually move forward, prospective cohort in your clinical trial. So let's take an example. This is Joe. It's no lie, when Joe opened up the lecture series that Joe and I went drinking. We did. We went drinking. It was to celebrate one of our Saudi Arabian exchange students from Aramco. They came over, they get to learn English, and they become a paramedic, and they actually go back to fund ventures in Saudi Arabia. Some of them are on the King's medical detail and their bodyguards. Some of them go work on oil rigs, whatever. So Joe and I, we went drinking. And so Joe's so excited. His wife's sitting next to him. He was out of the house that day. And so you can see that Joe has a little bitty drink because, you know, let's say Joe, when he goes out, he likes to binge drink, right? So when we talk about this, let's say we want to do a study, a case control study with Joe or people like Joe. And when we talk about this, let's say that our research question is going to be, in the patients who, let me see here, what is, see if I get, okay. So an acute MI in patients who decide to binge drink versus not binge drink, right? We will look at this. And let's say Joe had a rough couple of years, right? Joe goes out and he binge drinks all the time with whatever food drink he's drinking right there. Let's just call it a mini beer. So Joe goes out and we actually have a bunch of people that look like Joe, act like Joe, and we research them and say, okay, we're going to do the study. The occurrence of having an acute MI after 5 years of binge drinking is double that of those who don't binge drink. That's a case control example. Let's say we wanted to reword this question. Let's say, what's the effect on aging with Joe or people like Joe if they binge drink, right? How many gray hairs does Joe have on his head versus, you know, those who don't binge drink? And so we could actually just change that example. So again, these are examples of what are we looking for? We're looking for the effect of aging or gray hairs or the acute MI based on binge drinking or not binge drinking. And you can see that since 2016, 17, I think, which is the picture on the left, to 2022, the picture on the right, Joe must have had a couple nights of binge drinking because just count those gray hairs. But when we talk about the level of the study, you know, you often hear about animal and laboratory studies, and those really aren't involved in humans. So yeah, we know that certain things happen to animals, but we don't want to cross them over to humans. When we talk about case report and case series, usually we're looking at a write-up. Remember, I told you that EMS provider could write a paper on that pediatric stroke and say, okay, yeah, this kind of happened in Trumbull County, but that's it, right? It's something interesting to read. That evidence is low. We know it happened, but we can't make any clinical decisions based off that. So that's kind of low in the pyramid. Then we go to case control study, where we can look back and we have an outcome of interest and we're looking for a risk factor, such as is binge drinking related to gray hairs or the acute MI, right? And that's what that's for. And that has a little bit more certainty in the level of evidence. When we take a cohort study, we can look backwards and forward, and we're trying to find the outcome of interest, right? We're trying to figure out, did this cause that, okay? And then the best level of evidence that we can get is your randomized clinical control studies, and they test treatments, and they're prospective, they look towards the future. And that's where clinical practice and our guidelines come from. And so, yes, all research is great. Everything is great to read. But when we really want to get down to how do we implement and what do we implement, we really want to do, you know, the primary studies up and see how we can make these guidelines. Again, the randomized controlled trials are the highest quality clinical studies we can get to find an intervention. These patients meet a specific criteria, right? So let's go back to the seizure patients. All seizure patients are now a candidate for drug A in this box or drug B in this box. The patients are randomly assigned to either an intervention or a control group. The control group is usually something that we know is going to work and we don't mess with it. The intervention is something that, we're trying to experiment and find the question on. And that goes into what's called a PICO question. And we're going to look at that here soon. And then we're going to look for the difference of outcome. But there's some limitations, right? Sometimes we can't randomize that. Let's say that there's a pediatric seizure. And with pediatrics, we almost never do clinical trials on. So we know that if we are in an area that has prominent pediatric seizures, we're not going to be blinded. We're just going to go straight with what we know works. Sometimes, though, the interventions of the trial are so costly, we can't make them work without some grant or some funding through a hospital. But maybe also it's very time consuming to analyze all that data. All right. And again, we don't want to do these on just a handful of patients. We want to do it on all pediatric patients in Northeast Ohio, for example. All right. Again, maybe because this patient was seizing in a mall, we couldn't do the experimental treatment, or we couldn't go for drug box B versus drug box A, or something like that, right? And then we got to get together. We got to get somebody to who's familiar with data crunching in order to do this. So all those are great ways to figure out studies and how to present data, right? With all sorts of data and clinical trials, we have to have some ethics. So I kind of want to just kind of talk about some of these unique things throughout history, is that, up until 1974, there wasn't any ethical standard in doing some of these research topics. In the 1930s, Nazi concentration camps actually experimented on prisoners for a variety of things, right? In 1960s, the Milgram experiments, they actually were trying to teach people something. And they thought that if the teacher gave an electrical shock to a student, they would actually be able to learn better. Think about that. You're trying to learn how to be a paramedic and decipher what a P wave is. And when they say, this is a P wave, they go, right? And you jerk. You're like, well, I don't know what anything is anymore. So they thought that wasn't very good. And one of the biggest studies that was actually sponsored by the government and the National Health Service was the Tuskegee syphilis study. And so what happened is the National Research Service, they knowingly did not provide treatment to Tuskegee airmen when they had signs and symptoms of syphilis, because they wanted to see how the course of the disease panned out. So they realized that was bad. And in 1974, the National Research Act was implemented, and they developed regulations for human subjects in the Institutional Review Board to say that, hey, look, you can't just go ahead and just do whatever you want with people. They're people. You can't do that. So moving forward, in 1979, the Belmont Report decided that we're going to have some ethical standards. So we're going to have respect for people. So the respect for people, or the respectful persons, as it has on there, is we're going to make sure that the patient is informed and they make a free choice to participate or not. And those people who have lesser autonomy than others, we're going to make sure that we have some protections in place for them. Then they said beneficence, right, which is do no harm. We're going to make sure that the risk, if there are any risks, is kept to an absolute minimum. And then justice, we want to make sure what's good for one group of people is the same for another group of people, and that the research we're doing on group X does not benefit group Y. So these were put in place, and so that's why almost every single research proposal has to go in front of an institutional review board, even things like, for capstone projects. And we know already that we have to get informed consent on almost everything we do, right? So, but it's a little bit difficult in the pre-hospital setting. How are you going to get informed consent to take drug A versus drug B? Maybe A is epinephrine, maybe B is saline. And somebody who's in cardiac arrest, you can't get informed consent for that because the patient's dying or they're already dead, right? So then the government comes in, and the institutional review board comes in and says, well, we're going to have a waiver, and for those people who have informed consent, we're going to have that waiver. So those patients who are in cardiac arrest, we're going to say, go ahead and do it anyways, right? So the intervention is done with the waiver of consent, and that's usually the waivers are in place for life-threatening conditions. All right, but we know that it must not interact with the patient's medical condition. We know that the risk versus benefit must be reasonable, and we have to have everybody's buy-in from that, and we have to kind of disclose what we're doing. But all EMS research is not without any challenges, right? So there's, again, we talked about informed consent. Maybe the patient's wife does not want you using something on a patient, right? Because, hey, I'm going to use this experimental drug. No, you're not. You just get the patient to the hospital. Maybe it's difficult to randomize the intervention. So every drug box at Trumbull is blue. So if we knew we put a red drug box in there, hey, what's this box? This is a different box, right? We can't really randomize that. And then getting buy-in from EMS providers. It is hard to get EMS providers to buy in even to the backboard initiative. Then it would be, hey, I'm going to make every EMS agency under Trumbull's protocol, we're going to do something experimental. And people would, I can tell you right now, people would say, no, I don't want to do that, right? Sometimes it's not logistically feasible to get something done. Let's just say the pharmacy has a back order of drug X and we can't put in the drug box. And now our research study is pushed back, or by the time we were able to do it, it's now expired. And again, the continuity of medical records, right? How would you document patient cardiac arrest was given drug A out of blue box 100, right? That has little challenges. You would have to have somebody reading every PCR for cardiac arrest, to do that. And with a person of 2 people at Trumbull, it's kind of hard to do, right? And then what if, I said, EMS provider Larry Monero responded to cardiac arrest, and instead of saying I gave drug A out of blue box 10, I mix it up. I gave 5 milligram. I used a drug box ALS 10, and I gave drug with blue label to this patient. So we'd have to have a standardized documentation in my research, and so if I document something one way and you document something the other way, it's going to be hard for that researcher to kind of figure out what was really given. So that's kind of the background of evidence-based guidelines and how we get to where we're going. But now we need to kind of implement them, right? And so with these evidence-based guidelines, again, it's based on the systematic review of all the medical literature that's out there. You've heard Matt talk about how I dug through literature in order to make our protocol pretty progressive. And so the literature that I dug through was journals, American College of Emergency Physicians, pre-hospital disaster care, any journal that was out there, any journal I subscribed to, any journal I can get my hands on, I was looking to see what was done. And generally a good rule of thumb is anything published in a journal that's greater than, that's within the last 10 years is great. We typically, for research and doing new studies, we don't want to have research that's beyond 10 years old, because let's just take something simple like the AHA guidelines. What we did in 2010 is not what we're doing in 2020. Research evolves, new studies come out to kind of counter the previous studies or to reaffirm the previous studies. So when you are doing research and you are looking at something, I start with 5 years and then I go back, but I don't go back any further than 10 years. Then we present it. So when I find, let's just use congestive heart failure. When I found that 1 milligram of IV nitroglycerin was much better than sublingual nitro tablets or nitro paste, I went to Matt. I told Matt, this is what's good. Let's try it. All right. I like what you're saying. I like what I read. Let's go to Dr. Swift. Dr. Swift. Okay, let's do it. Dr. Swift, this is what we found. This is what we got. He's like, you know what? That makes sense. Let's do it. So we went from the EMS protocol director to the medical director, and now we presented the training back in August to the people in our protocol, and now we presented to everybody, the 250 participants that are on this, who are registered for this EMS refresher. They got to hear about it, and hopefully they take that and they do the same thing I do with Matt, and they go and say, hey, look, let's affect change, let's do something, right? And then, when we do research and we try to implement these evidence-based guidelines, we want to ask a specific clinical question. And so for us with the CHF initiative was, how many patients given 1 milligram of nitroglycerin through an IV do not get intubated upon arrival to the ER, something like that. And so once we implement this for a couple of years, we'll be able to go back and we can say, hey, only 18% of patients arriving via EMS who were given 1 milligram of nitroglycerin via IV were intubated, but 70% of patients presenting to the ER, maintained and had an oxygen saturation. It could be, put in the ICU with BiPAP. something like that. So we develop these clinical questions and we move forward with it and we present on that. And again, how do we get everybody to do it, right? So provider A on the same ambulance or at the same fire department as provider B, one might be very familiar with IV nitroglycerin. They went through the training, the other one's not. And I was like, I'm not touching that. I'm going to open up the CPAP seal. I'm going to throw another sublingual nitro on the patient's tongue, and I'm going to put that CPAP seal back on. Well, then how are we able to measure the outcome of that patient? So we got to get the buy-in from everybody. We got to document it, and we got to make sure that we provide high-quality patient management and outcomes for that. But Larry, what if we just read all the research that's published every single day and we keep up on everything, and that's going to make all the world of a difference? Well, you can't. Well, I guess you could, but if we tried to read everything, it'd take us almost 14 hours a day, right? In 2010, they found out that over 75 clinical trials and 11 systematic reviews were published every single day in medicine. So if you could actually read it, and it took about 10 minutes a day to read everything that was published, it'd be over 14 hours a day to read all the medical stuff that is out there. So it's just not feasible to do that. So we try to stick to a topic. Like when we redid the protocol, we said, okay, we're taking the cardiac protocol and we're finding all the research. And it took us a month and a half to decipher through it and write these new protocols. So again, we're doing what we need to do in order to provide the best patient outcome. We already know that the evidence-based guidelines help us to do a couple different things, right? It's going to decrease the amount of work that we have to do in order to give the best medical evidence that we need to provide with the patient. So maybe we look at prior guidelines, right? Maybe we look at these systematic literature reviews. Maybe we look at summaries. And sometimes we even look at peer-reviewed research. So peer-reviewed articles are those that are found in like EMS World and those are trade journals rather. So when we talk about peer-reviewed research, we're looking at the Annals of Emergency Medicine. We're looking at the American College of Emergency Physicians. But evidence-based guidelines will help us start our foundation of what we want to do. It's also going to help us determine if it's worth incorporating into our practice based on what's currently available, what the evidence says, and can we implement it, right? If we were to say at Trumbull, we're going to try to get, we mandate, everybody to have a Straker power cot, by 2023. Well, that's just not feasible because they're $30,000, $40,000 a piece. And then you got to have a track system, a power loader. It just doesn't work, right? So the good thing about our guidelines is that, when we tell you we're going to give you a drug or we're going to do a new drug, we provide that drug. So the cost is purely a Trumbull for all the drugs that we give. But then also the guidelines will help us review the evidence in order to answer the questions that we want to improve the patient outcomes on, right? So let's go back to CHF and we want to say, okay, well, these guidelines, IV nitroglycerin should help decrease the amount of intubations upon patients arriving to the ER. We also know that the evidence-based guidelines provide recommendations, right? So this here is a snippet of the American Heart Association opiate algorithm here. And so, this is something we follow. We have it ingrained into our brain. And we know that if you have suspected opiate poisoning, if the patient's breathing normally and they're about to, go on or they're unresponsive, we're going to give some Narcan. We know that the patient is not breathing normally, we're going to start CPR, right? So we already use the evidence base for these guidelines to go into patient care. And so that's what we're trying to do pre-hospitally with our protocols is use what's already out there and affect them into what our treatment needs to be. And everybody uses it, right? NAEMT, the American College of Emergency Physicians, National Association of EMS Physicians, the National Registry, everybody buys into the evidence-based guidelines and it's incorporated into our everyday care. So from evidence to guidelines, obviously in order to get this done, we have to provide some scientific research. We have to develop the question. We have to look at the population we want to study, and we have to carry out those studies and crunch that data. Then we have to look through other studies that are already out there. We have to take the recommendations based on the experts. We have to, figure out, do we have the patients or do we have the EMS buy-in? Can we incorporate these judgments, in these clinical judgments into our providers? And then we have to consider the values and preferences between the patients and the clinicians, right? And all of this takes time and effort. Somebody asked me, Larry, why is it taking over a year for you to write for us to write the new protocol? Well, because everything's evidence-based. You don't want me or Matt or Ken Jones to go ahead and pull the first article we see on something and then say, this is what we're doing, right? That'd be irresponsible of us to do that. So we want to make sure that we find the best, we look at the best, and that we're physically able to do that. Again, we're not huge into research studies and producing the research here at Trumbull, but we will analyze it. And so we're going to analyze all the data we can get. We're going to protocol. We're going to make sure that our evidence-based practices are in there. We're going to present all the research that we can for you guys to do. And then we're going to, write our protocols based off of that. And those guidelines are usually developmental groups that by NAEMT, by American Heart Association, CDC, they're going to provide their guidelines, their recommendations based on the research they did. And all together, we can take the stakeholders and we can take the evidence that we have, we can mesh them together, and we can provide an evidence-based protocol for everybody. And again, with the best patient outcomes in mind. So again, in order to create something, we need to ask the right question. We have to involve the right population. We have to analyze the data, and we got to come up with the accurate conclusions for the future practice. And when you do all of this, and if you are active in research, there's a bunch of stuff that you have to do, right? We take the external inputs. We then look at the initiation, and we go through the evidence. We look at that evidence, and we say, hey, we don't really have a lot of case studies on this. This is just one case control or one case report of this, like that one pediatric stroke. We really can't take that evidence for it. But when we do get good evidence, we're going to look at the guidelines. We're going to come up with our own guidelines. We're going to make a protocol. We're then going to disseminate that protocol and distribute it to everybody that we have on board and have their feedback on it. We're going to try to implement that. We're going to evaluate the effectiveness of that protocol, and then we're going to go back and going to reinitiate the evidence review again. So external inputs is what already exists, right? We're going to look at the existing protocol. We're going to look at the existing guideline, and we're going to see what we can have, right? And again, that's going to take from the local protocols that are in our area. It's going to take from other state protocols. We're going to put them all in. We're going to look at them, and we're going to decipher that. We're going to ask the question we're trying to answer, and usually that is, how can we do this better? Or should we use tourniquets to control hemorrhage? Should we use aspirin to patients with chest pain? We're going to look at all that, and we're going to see what happens. And then the question is going to be searched based on the PICO format. And when we talk about a PICO format, we're going to talk about the patient, the problem. We're going to look at the intervention. We're going to compare that to the control, and we're going to look at the outcome. The questions could be about the intervention. It could be about the diagnostic test, or maybe the screening method, such as we introduced the band stroke scale or screening tool throughout this refresher. It might be the prognosis that I talked about, CHF and the rates of intubations or the discharge to hospital. It could be the risk factors that we're trying to figure out. But one of the things we want to know about the patients is we can say, a female patient at the age of 33, right? We can get specific with that. We can talk about the clear description of the intervention that we want to do. We can compare it to what we're not doing, and then we can see the outcome that we're trying to measure. The questions can also be about the interventions or therapies. Were they randomized? Was the case control? Was it a cohort? We can look at some diagnostic tests, for example, to identify a disease, such as a STEMI with a 12 lead, right? We can talk about risk factors for specific illness. Maybe the likelihood of a patient has a serious illness based off of the trauma score, right? The revised trauma scale. So we can look at all this, we can form a question. So this is an example question. In a pre-hospital patient age over 35 with chest pain, does the administration of aspirin versus no aspirin reduce mortality? So let's go ahead and let's figure out our PICO component. So P is for patients, and that's going to be pre-hospital patients who are 35 years or greater. The intervention is going to be the administration of aspirin. The control is going to be no aspirin. And what are we trying to find the outcome? Mortality. And so that's how a research question using the PICO format is actually developed. Here's another one. In a pre-hospital patient's age greater than 18 years of age with potential spinal cord injury, does placement of a cervical collar versus no cervical collar reduce long-term neurological deficits from spinal injury? So looking at the PICO format, our patients are people greater than 18 years of age with a potential spinal cord injury. The intervention is placing a cervical collar. The control is not placing a cervical collar. And the outcome is reduced long-term neurological deficits from spinal cord injury or from spinal injury. So when researchers get together and they try to do this, they form a PICO question, they conduct the research, and they answer this question, kind of like the scientific method that we talked about. So when we are looking at literature, usually PubMed is a very good one to look at. At best, go through the CINAHL Complete is good, but usually those kind of require some subscriptions to get to some of that stuff. Google Scholar is a new and upcoming thing. When I was, in college, we didn't really have Google Scholar, so we had to go through the library. PubMed had to enter the YSU barcode. My student number, had to, figure out what I needed to do in order to get onto the research-based database. And then I was like, oh, by the time I got that, I was like overwhelmed with trying to figure out what I needed to look for. Now, Google Scholar is really good because it compiles almost everything from every database, and you dig deeper with that. When we do implement these guidelines, right, when we do talk about congestive heart failure and the IV nitroglycerin, we're pulling from peer-reviewed literature. And that peer-reviewed literature is, the Journal of Pre-Hospital Emergency Care. It's the Annals of Emergency Medicine. It's the Pre-Hospital and Disaster Medicine Journal, or maybe it's American Heart Circulation. Those are peer-reviewed literatures that is more scientific than what something you might read in a trade publication like GEMS or EMS World. They report on, hey, Trumbull Regional Medical Center is implementing IV nitroglycerin for congestive heart failure. Their results look promising, yada, yada, yada. But then where do we get that from? We get that from those journals, and then EMS World may have written on that. We have to evaluate the evidence, right? And so that's going to be the study design. Do we have any bias in there? Did it address the population? Did it have any forms of consent? And then we look at the grade method. And when we look at the grade method, how is all this evidence compiled? Well, we formulate a PICO question. We look at the outcomes we want to do, and we report on that, right? Is it critical, non-important, or important? We decipher all that into a data table. We look at that grade profile. We look at that evidence with a grade pro, which is like a table, and then we rank that information based on high, moderate, low, very low. Then we get all of that, we grade it, then we look at the critical outcomes. Those outcomes are then sent to a panel, and that panel will say, we recommend using this, we suggest using that, we recommend against the long spine board, and then they implement that into the protocol. So it all started from a question. Somebody said, what can we do better? And it moved from there. And the next thing you know, it's in guidelines. And again, we have to develop it, right? We have to get the medical director, we have to get the EMS buy-ins, we have to get the hospital administration on board, and we have to have everybody say, yeah, let's do this, right? And so with this, we have to weigh the risk and the benefits. We have to account for the values and the preferences of the population. And again, can we get this done in real life? We do the model protocol, right? Maybe the Trumbull Regional Medical Center protocol doesn't fit the town of New Amsterdam, right? But maybe it fits the town of Youngstown. So we have to adapt to that. And so they might say, you know what, we can do everything but RSI in your protocol because we don't have a way to lock up the paralytic. Okay, that's cool, right? But we got to be able to adapt. We got to be able to evolve, and we have to keep everybody in mind. And again, we have to adhere to the scope of practice, right? We can't just go out and say, hey, we're going to do this because Dr. Swift says so. Once we implement something, we have to educate everybody, and then we have to bring them in and make sure they understand it by giving them maybe a little bit of a quiz. And then we have to break it apart, right? So we need to make sure that people are reading it, people can get to the protocol very easily. Maybe we need to get, classroom training. Maybe we need to get SimLab training. Maybe, our stuff goes so far that it's in a standardized course, right? Maybe we can influence American Heart Association to say, hey, we're going to give IV nitroglycerin versus sublingual. But usually the stakeholders like the AHA, the alphabet soups out there can kind of help us based on research that we do to get it implemented. And when we do get it implemented, we got to have a buy-in support of everybody involved. We have to train everybody, and we have to make sure they're very comfortable with medication. We have ketamine in the box, and there's a handful of EMS providers who will not give ketamine for pain management simply because they don't know how to draw it up. They've been taught, and they're afraid of it. And a lot of the negative stigma comes from they heard stories from other people, or they read that one case study about it, and they're now scared of it. But we got to make sure that we use the evidence, we trust the science, and we move forward with everything that we've implemented. And again, everything that most of the, stakeholders, American Heart Association, Trumbull, these are all safe. And if you do things how we expect you to do them, the patient's going to have a good outcome. So again, it's hard to implement any type of change, especially evidence-based guidelines. We need to make sure that we get people involved and that we roll it out all at once, right? It could be limiting because of issues. Let's say we don't have a lockbox on the ambulance and we can't secure that paralytic. Well, now that village of New Amsterdam can participate in RSI protocol, right? But maybe we can't convince all of EMS in order to say backboards are not good. We're going to try, but getting them to do it is something else. So how do you would have to ask yourself, and it's a rhetorical question, how are you as an EMS administrator going to, or EMS medical director, how are you going to get that implemented change if people are resistant to it? It could be pretty hard. So when we do implement change, right, we got to make sure that we take time to do this. Usually EMS agencies, when we change things, it averages over 1 year to implement national guidelines such as cardiac arrest. Let's think about this. Let's say your ambulance company, your fire department, let's just say that they have 30 people on staff, right? 30 people on staff with ACLS cards or BLS cards. Some might expire at the change right before the guidelines are out. Some might expire after the guidelines are out. It could take over a year, sometimes maybe 2 years, for everybody to be on board with the new guidelines for cardiac arrest management. So either you train everybody at once, which would be ideal, or you just realize that it's going to take some time to get things done. So you might say for fire department X, people expire within the next 2 years, that by year 2.5, we're going to change everything. That's a long time to get something done, but it could be like that. And so for clinical research, in order to be done, it could take sometimes up to 17 years. New drug medications can take up to 20 years, right? So we just have to be patient with everything and make sure that it works. And the mRNA technology that's found in the vaccines, that was done in the 1970s. So it's out there. Cancer research drugs have like 30 years. Metformin took almost 20 years to do. In order to get this done, EMS agencies can implement some toolkits initiatives, but you can get them there and you can find all of these things. And then you have to evaluate what's going on. Was it truly implemented? In 2015, we took out backboards, right? But was it truly implemented? Our answer would be no. Why? Because last year, somebody took a patient, put a patient on a backboard. This year, somebody immobilized somebody because they passed out. So no, we did not, people did not do a good enough job implementing what they wanted to get done. Is it cost effective, and are we having good impacts as well? Most of the data that we get is from the NEMSIS, right? When you have validation and you have that QA administrator and you go to do your EPCR and you're, oh crap, I got a checkbox or I got a red mark or I can't lock it out. That's because that NEMSIS requires certain things in there. When we talked about pain management, we talked about, you should put your pain scale in the vital sign aspect so that they can track whether fentanyl decreased pain versus writing it in the narrative, right? That's one way that they get things. The other way that they get information is through the CARES Act. And so when you do a cardiac arrest, it's going to ask you, was an AED used? Was the external defibrillator? Was there bystander CPR? Did you get ROSC? A whole bunch of questions that's in your EPCR, but that's why that's done because the CARES Act, the CARES, the Cardiac Arrest Registry to Enhance Survival, takes all that data, the AHA analyzes it, and they're going to come up with the best practices. And that's how we figure out that early CPR and defibrillation, public access to defibrillators help to increase the ROSC rate. Again, Justin talked about the National Highway Transportation Administration, doing their evidence-based guidelines, such as car seats and why seatbelts work. And they have a big influential aspect on EMS. But just about anything you look at with EMS has an influence on what we do today. American Heart Association, the College of Emergency Physicians, National Registry, NAEMT, and ASEMSO, flight organizations, right? The American Academy of Pediatric. They all do the study. They provide us all with the same amount of guidelines, the same research that's out there. And in order to have a good protocol, you have to go out and find it. And that's up to the protocol team in order to take that research, disseminate it, and put it into their protocol. I know that was really long. Most of the guidelines can be found at the prehospitalguidelines.org. And again, some of this stuff was adapted from the Pre-Hospital Guidelines Consortium. And that's a lot, right? So if you were participating in the Google Classroom, you saw me put out little notes, and it says, make sure you drink coffee because it's going to be very long and wordy today. But it's there. I hope you guys can understand some of this stuff. But it's not just we find something and we're going to implement it. It takes a long time to get done. Real quickly before Matt takes over, I just kind of want to show our tentative schedule for February. So what we have here is we told you that the state and local topics are still being developed when we, excuse me, when we put out the syllabus. So we have Dr. John Melville. We were able to secure him actually this morning. He's a pediatric abuse physician. He's going to talk about child abuse on Thursday, and he's also going to talk about pediatric case review. Next week, we're going to have Captain Phil Lucarell and Matt Gordon. They're going to talk about tactical EMS and fire rehab. Moving forward down that, next Thursday, we're going to have author Dan Limmer. He's going to talk about death and dying. And Joe and I hopefully will talk about geriatrics. After that, we're going to have Teleflex, the medical device manufacturer for EZIO. They're going to give us 1 hour CE on placement of intraosseous needles, where you can go. Then Justin Coper is going to talk about helicopter utilization outside the realm of like long distance time to transport, and also landing zone safety. Natasha Kramer from Meridian Healthcare is going to talk about the well-being of the EMS provider. Dr. Grafaro and myself are going to talk about sports injuries. Hopefully Joe won't gouge his eyeballs out talking about geriatrics. We'll come back and talk about that again. Then Paige Wolfberg and Worth are going to talk about EMTALA. That's going to be your long wait times at the ER, whose responsibility is it when you have to wait 3 hours to manage that patient before you get a bed. They're going to have a 3-hour segment. And again, any legal question that you kind of have with that, please write it down. The presentation should take about 2 hours, maybe 2.5, and he's willing to stay the extra hour to answer legal questions about that. So we're very happy to secure them. Captain Renee Waldo, the Vienna Fire Department, is going to talk about EMS documentation. And Chip Comstock, who's a local attorney here in the Youngstown area, is going to talk about legal issues in EMS. And then the trauma services at Trumbull and the residents are going to talk about trauma review on March 1st. When you add all these hours up, you're going to have not only everything you need for National Registry, but you're going to have every single hour of every single piece of geriatric pediatric trauma that you need for Ohio as well. So again, we want to make sure that we give you all the opportunities to learn everything. I'm going to put this syllabus, the new tentative guideline up as well. And then so you guys can kind of be informed of what's going on. But I want to thank you for your time. I know it's been a long night, but of some very dry stuff, but I appreciate you being attentive.
All right, thanks, Larry. Appreciate your time and sharing your talents with us tonight. Same with you, Justin Coper. Very informative. You know, I guess not every single subject can be terribly exciting, but I don't think I picked up some pointers and some things that I didn't know before. So I guess no knowledge is wasted. Are there any questions out there? Questions, comments, concerns, complaints? No complaints. All right, well, that's excellent. Well, I appreciate everybody's time tonight. Larry gave us the rundown of what we have coming up over the next couple of weeks. There will be more even after that. So everybody stay tuned, and I guess we will see you on Thursday at 6 o'clock. Look, you got out 5 minutes early. Appreciate it, everybody.
Hey, Matt.
Somebody had a question for Matt or wanted to talk to Matt?
Are you gonna be in the hospital tomorrow?
Sorry, Dan, I didn't hear you. Yeah, I'll be here tomorrow. What do you need?
Just want to talk to you about this login gig. I'll get with you tomorrow.
Okay.